A 50-year-old farmer who is a non-ethanolic, he arrives in ED unconscious after unknown poisoning. And the examination findings I just mentioned, his pupils are pinpoint. So what will be your differentials?
Sir, pinpoint pupils can be the causes of pinpoint pupils can be uh, organophosphorus poisoning,
Okay.
and
And
frank opioid poisoning,
yes, opioid poisoning.
and
And think
those are
about think about non-toxicological causes also. Just for completion's sake. Okay. In it, non-toxicological causes of pinpoint pupils. Okay. Okay.
so organic causes in related to the central nervous system, pinpoint pupils.
Hmm. Okay, fine. So you said that it can be organophosphate poisoning or opioid poisoning. So how will you differentiate between the two? Or how will you, arrive at a conclusion, okay, this is organophosphate or this is opioid?
Sir, a classical history related to organophosphorus poisoning with the if the person if the family was brought, the relative has come with an empty bottle in their hands, and a classical history of consumption, and a classical on an examination, a typical breath. Uh, uh, the com it's a complete.
What is the typical what is the typical breath?
It's the acid. The acid.
Okay, fine. Go on.
Sir, apart from that, the mm,
Okay, that will be diagnostic of
that
OP. Okay.
that will have a solution. Yes, sir. As far as opium poisoning is concerned, um,
So on examination, how will you differentiate between the two? Or how will you use the toxidrome approach to differentiate between the two?
one is highly cholinergic, sir.
Yeah.
The opium poisoning is completely cholinergic. He will
Hmm.
be patient will be um, like dry, completely dry. Is
Yeah,
and
exactly.
no, the patient will be completely clinically dry in case of the opium poisoning and sorry, organophosphorus, and the same will be absent in the opium poisoning.
Fine. Okay, so he's having increased secretions, bronchoria, then chest shows crepes, and there is bradycardia hypotension.
Very good.
So now comment on the role of activated charcoal in this case.
So activated charcoal will be the role of activated charcoal will be applicable only if the patient arrives within first 2 hours.
Yeah.
After that, there is no role for the
Okay.
activated charcoal.
Okay.
And
So how much will you give? What's the dose of activated charcoal? Whether you give as a single dose or multi-dose.
so we give it as a single dose.
Okay. How much?
Some dose I don't
Fine.
remember.
Okay, fine, no problem. So name some situations where multi-dose activated charcoal is useful. You said you will use single dose activated charcoal. So some situations where multi-dose is useful. Or you will consider giving multi-dose charcoal.
Um, in case the toxin is repeatedly secreted in the gastric mucosa, the over a period of time from the blood into the gastric, like in the case of then over a period of time, it can be um, activated charcoal multi-dose activated charcoal can be given.
So how will you know that the toxin is being secreted repeatedly in the gastric?
Um,
Or only
the,
if you
the
know that,
nature
then
of the
you'll.
toxin itself will tell us, that is, the toxin has to be more big.
So yeah. So what are those toxins practically which you find MDAC useful? You know? Okay, fine.
So in this case, it is the morphine or the
Okay, we will see. No problem.
right, sir.
Okay, so this question I think you already answered. How will you establish the diagnosis? Clinical? Any investigation?
Sir,
Any
apart from
investigation which will aid you in your support of your diagnosis?
so toxic in case of in case of an opium
No, no.
poisoning, sorry,
This is
organophosphorus,
no. Yeah, we are talking about OP poisoning.
OP
Okay,
poisoning.
one you mentioned already clinical. Your
Yes,
smell,
sir.
typical breath, then signs, and any other investigations?
In case of the
Yeah, we are mentioning about OP poisoning. Okay,
right,
forget
sir,
about the
I got
opioid
it
part.
only for only
Uh,
the opium poisoning part.
okay, any investigations which will aid in your diagnosis in case you have a confusion. Okay, maybe patient might have ingested a combination of compounds, and if you want to know whether patient has ingested an OP compound, which
One is the
investigation will
gastric
you?
aspirate itself, which can be sent.
Yeah, but that will take time. Yes, definitely,
Secondly,
definitely
sir,
toxicology.
toxicology. Uh, Second will be the
Fine, no problem. We'll
conversion
see.
of opium. So,
We will see. We will see. So in this patients with OP poisoning, some may have hypotension, bradycardia, and sometimes they can even have hypertension and tachycardia. Why these both spectrum occurs in a case of OP poisoning? You got my question, right?
yes, sir, I got the
In a case
question.
of
Why
OP
these
poisoning,
two
patients
genes
can have, yeah, patients can
generally
have
should be
hypertension,
collided?
bradycardia, as well as hypertension, tachycardia. Why the uh, either ends of the spectrum occurs? Why? Why hypertension, bradycardia occurs?
Sir, hypertension bradycardia is because of its cholinergic. It's a cholinergic toxidrome. That is the reason there is
Yeah,
hypotension in bradycardia. But hypertension
yeah.
and tachycardia, tachycardia
Can
was
you?
was
Hmm. No, it is cholinergic, definitely. So, in other words, can you mention the effects, the receptors at which OP acts? Then that will help you answer this question.
postsynaptic anticholinergic receptor. Sir, it
So, what are the cholinergic receptors? What are the different types of cholinergic receptors?
nicotinic and muscarinic.
Yeah,
So,
great.
muscarinic effects can also cause the nicot
Okay, fine. Yeah, this muscarinic can cause.
muscarinic cause tachycardia and
Okay, we will see. Now you know the antidote. So, how will you dose the antidote, or how will you give the antidote?
opium poisoning, sir, organophosphorus poisoning. Okay, the antidote is the first line of treatment antidote is
Yeah.
atropinization of the patient. So we go ahead with 1 milligram doses, 1 milligram stat to be
Mhm.
repeated every um 10 to 15 minutes. Then complete atropinization has occurred,
So
or
you give
till
one, you start with 1 milligram, then you repeat another one
up
milligram
to 3
after 15
milligrams,
minutes.
up to 3 milligrams.
So how will you decide that? Okay,
Up.
so you have given
So,
1 milligram stat. Then how will you decide? Okay, after 15 minutes, how much should I give? How will you decide that?
on the basis of, sir, absence of crepitations and then heart rate, target of heart rate beyond 100, My
Mhm.
target levels, I'll have my specific target level, sir. Systolic
Okay.
blood
So
pressure
so
beyond.
you are talking about the endpoints of atropinization, right?
Right, sir. And right to be
Okay.
the
So better
specific
use that term.
endpoints.
Okay, fine. So what are the endpoints of atropinization?
Sir, it is heart rate beyond uh, 100, systolic BP beyond 100, and um complete absence of crepitations.
Mhm.
Like, and pinpoint people is not included in that.
Okay. Fine. So you have repeated atropine till you reach that point. Okay. Now, how will you continue or maintain the atropine dose? You said you will repeat the atropine dose till these endpoints are achieved. And how will you maintain? You cannot finish with that, right? How will you maintain the atropine dose? Or what will be your maintenance dose? Fine.
Fine,
So,
sir.
okay, fine. We'll see later. So you are plan. You have given atropine. So what will you which intervention or which procedure will you do prior to giving atropine? Or yeah, what do you think you should do? Fine.
Apart
Now
from
coming to the
monitoring, sir,
a small procedure, small intervention, a procedure which you regularly do. What's that procedure? Ideal to do if you're giving, if you're atropinizing the patient. Okay, fine. We'll see. What's the role of PAM?
radical design. So role of PAM
Yeah.
is only within the first initial phases of the uh, if the patient presents only within the initial phases of presentation.
Mhm.
Uh, Within first 2 to 3 hours only, paradoxime is effective. And it,
For all compounds,
so sir, for,
for all organophosphate compounds.
uh, no, sir, for carb. Uh,
In fact, what are the different types of OP compounds?
Sir, it has carbamates and organophosphates.
So,
It is effective only in
uh,
organophosphates, not in
fine,
uh, carbonates.
fine. And
And
organophosphates, the two types. Okay, fine. So you said you will give PAM only if the patient presents to you early.
hmm,
So what is the evidence? What's the dose? And for how long will you give? Okay, fine. We'll see later.
I don't remember, sir.
Okay, we'll see. And any other drugs with possible benefits? Any other
Uh,
drugs which you can use with theoretical benefits apart from atropine and PAM? Okay, fine. Okay, so you have maintained the patient on atropine infusion,
yes,
and currently patient is receiving atropine at 30 milligrams per hour infusion for the last 3 hours. But still, his heart rate is 90 and BP is only 80. So, first, what do you think? How will you manage? What do you think the situation is, and how will you manage?
sir. In case the heart rate, despite atropinization, then the fluid
Hmm,
status, other things, other reasons, the baseline fluid
hmm,
status of the
hmm,
patient has to be assessed.
hmm, hmm.
And is the poisoning only organophosphate, or there is some other added additional poisoning related to it?
No, patient had bronchoria, salivation, lacrimation, urine defecation, everything. You started on atropine. That part got improved, chest became clear, secretions came
But
down,
only the hemodynamics of one.
pupils,
Okay.
pupils around mid-size, but heart rate and BP is still on the lower side despite this much dose of atropine. So, what do you think you are dealing with? Okay, fine. Anyway, you will have to look about the hemodynamics and that parameters definitely, but that you will initially initially assess and rectify, right? In the initial part itself, you will rectify. Still, if BP is not picking up, you still have to reevaluate the hemodynamics, right? That part is okay. But specifically, what is the situation? Fine. Okay, so now on day 2, patient is on atropine infusion. He becomes agitated, restless, hallucinating, and has a temperature spikes of around 103 degrees Celsius. So what do you think he's having?
He's having
Post? He's having post? Okay, fine. Okay, fine. Then how will you manage? Okay, fine. That we'll see later. Now, day 4, day 3, day 4. Now he has become conscious, he's obeying, and his symptoms have reduced. And on day 4, you find that he is not lifting his limbs. When you assess the power, it is around 2 by 5
post-poison
in the proximal
paralysis.
muscles, post,
What
and
is
there is desaturation, and he has developed tremors also. What is that? What is the diagnosis?
we have read it, but I'm not remembering it.
Pardon?
It's post-poisoning
Post poisoning?
paralysis is
Yeah. Proximal muscles power is
proximal.
less. He cannot lift his neck, and his breathing is impaired. Saturation drops, and there are some tremors also. We are talking about organophosphate. Patient came with symptoms of organophosphate, and we have diagnosed organophosphate toxicity. We have started treating the patient as organophosphate toxicity, and now he's having this. Right?
So this is due to the chronic effect of the chronic effect of the binding of the organophosphates to the and non-regeneration of the acetylcholine.
What is it called? What is this situation called?
I don't remember that. So.
So fine, no problem. We'll see. Okay, now anyway, you have treated that. Now patient is now better. In between you had to do a intubate, then do a tracheostomy, and now he's decannulated and is planned for discharge by around 4 weeks. Let us say 4 weeks. So what will you inform the patient and bystanders when you're discharging or this point of time? You're discharging the patient who was admitted with organophosphate poisoning. And what will you inform the patient and bystanders? Or what long-term sequelae are you anticipating? Right.
Long-term muscle weakness, sir, and
Muscle weakness recovered. He's fine. That is why you
that
decannulated.
the syndrome is called intermediate syndrome. I just
Yes.
remembered it. Sorry.
Okay. Okay. So
It was
intermediate
called
syndrome
intermediate syndrome.
that is resolved. Now you're discharging the patient. So what do you think you should inform the patient and bystanders so that they don't come back after a few days complaining of something else? Okay, fine. So the last question. Can you name another poison which mimics organophosphate? I mean, the actions or the clinical picture will be more or less similar.
The
Sometimes you will be
tropabelladonna.
No.
Sorry.
Okay, fine.
Sorry, it's actually the opposite way I spoke. Sorry,
Yeah,
sir. It's
yeah.
actually the opposite I spoke.
So symptoms will be more or less similar, but your atropine won't be that effective, and you will most of the times you will treat it as a OP poisoning. it is relatively less toxic or less problematic than OP poisoning. So, okay, fine. So, Sudarshana, shall we move to the debriefing session?
Surely,
That was the last
definitely.
question.
Yes, definitely.
Okay, fine. So, Prithvi, so our case, 50-year-old farmer he was an ethanolic,
Yes,
and
sir.
he came with the intoxication. He took something mixed with alcohol. People were pinpoint. Right. So my question was, what are the differentials? So I was asking about the differentials of pinpoint people. You rightly pointed out it is organophosphate poisoning. It can be opioid poisoning. But also think about the other non-toxicological causes also. That is pontine stroke, pontine hemorrhage, or use of pilocarpine. Okay. Definitely in pontine hemorrhage or pontine stroke and the other cause, the other symptoms will not be there. The sludge and numbers will not be there. Okay. So regarding toxicology, the toxicological cause of pinpoint peoples are opioids and organophosphate, right? Now, how will you differentiate? That is, how will you use a toxidrome approach for differentiating? This is how you use the toxidrome approach. So when you look at the pupil size, if it is pinpoint, then it can be either opioid or we are cholinergic, right?
Yes, sir.
So what will you then look at? You said you will
Answer.
look at the skin. That is right, because in opioid poisoning, there will be diaphoresis, while in opioids, it may not be the case. And you can look at the bowel sounds. In opioid, it will be hyperactive, while in opioids, it will be hypoactive, because opioids are basically which will depress the motility of the gut, right? So this is how you differentiate. Same thing. And regarding the initial management, okay, just I'm adding the point, gastric decontamination within 1 hour. And don't forget about skin decontamination. Okay. And activated charcoal, it is ideal if done within 1 hour. Okay, maybe we can give up to 2 hours. Then beyond that, there is no much effect, because activated charcoal binds the toxins, the unionized toxin, which is present in the gut. So once the toxin is absorbed into the system, then there is no point in giving activated charcoal, right? And usually we give single dose activated charcoal. The dose is roughly 1 gram per kilogram. That will roughly around 50 to 100 grams. We give as a single dose. Okay. So that the toxin will bind to the surface of the activated charcoal. And we usually give a cathartic along with that, because the toxin binds to the activated charcoal. Now we want to eliminate the charcoal. Okay. For that we will usually give sorbitol or some other cathartic. Okay. Now, another point regarding the dose of activated charcoal is, so what will happen? The toxin will bind to the activated charcoal. Then after some time, the toxin will again get re-released. Okay. So in order to prevent that, it is advised that always the dosing, that is the activated charcoal to the toxin ratio, should be somewhere around 10 to 1, 10 is to 1. But we cannot, or we may not actually know the amount of the toxin ingested, but just know that the amount of activated charcoal should be 10 times that of the toxin injected. Okay, even though practically we may not be able to dose accordingly. The point is we have to give 1 gram per kilogram of activated charcoal, single dose.
Yes.
Okay. And regarding the multi-dose activated charcoal, generally there is no benefit of giving multi-dose activated charcoal. And it has some role when the toxin has some enterohepatic circulation. So the toxin is absorbed from the gut, goes in the enterohepatic circulation, then again comes back. In such cases, giving multiple doses of the activated charcoal may be beneficial, as in cases of carbamazepine, phenobarbital, quinine, dapsone, and theophylline. These are some of the poisoning where multi-dose activated charcoal is useful. In all other cases, single dose is advocated. And this activated charcoal has no alcohol poisoning, acid poisoning, alkali poisoning, and electrolyte, that is lithium, sodium, magnesium, etc. poisoning. There is no role for activated charcoal. It won't bind with that. Okay. Hope you got the point. And regarding multi-dosing, you give 1 gram per kilogram, followed by 0.25 to 0.5 gram per kilogram as the initial dose, followed by around 10 to 25 gram every 2 to 4 hourly. Okay. Now, the side effects of activated charcoal is GI complications and bowel obstructions. That is why if you these GI complications are more common with the multi-dose activated charcoal. Single-dose activated charcoal, the complication rate is very much less. But when you give multi-dose, the complication rate goes up. Okay. And most common is bowel obstruction. And this is contraindicated when you are suspecting an intestinal obstruction or bowel perforation. Okay. If you're suspecting a bowel perforation or if you're suspecting some sort of intestinal obstruction, then this activated charcoal is contraindicated.
Right, sir.
Okay. Then why both hypertension and hypertension can occur in this patient? So that is regarding the receptor at which this act. So as you said, it can act on the nicotinic receptor as well as muscarinic receptor. Muscarinic receptors, this muscarinic receptor action can produce hypotension and bradycardia, while the central nicotinic receptor action can produce tachycardia and hypertension. Okay. So you have to know the receptors at which OP poisoning acts. Once again, nicotinic receptor, muscarinic receptor, nicotinic can be in the neuromuscular junction as well as in the central and autonomic ganglia. That is where this tachycardia and hypertension occurs. And muscarinic in the endocrine and smooth muscles produces bronchospasm, then bronchoria, then salivation, etc. And the M2 receptor. M2 receptor is found in the heart, which causes bradycardia and hypotension. Okay. And regarding the antidote, it is atropine. But remember, atropine only acts at the muscarinic receptors. Atropine does not have any action at the nicotinic receptors. Okay. So atropine won't reverse the neuromuscular weakness. Atropine won't reverse the CNS effects. And you start with the recommended strategy for giving atropine is you start with somewhere around, in the Western literature, it says 1 to 2, but we have ampules of 0.6, so we can start somewhere around 1.6 to 3. You give 1.6 milligrams atropine and then double the dose every 5 minutes till the endpoints are attained. Endpoints you already mentioned, that is heart rate, tachycardia, heart rate, BP, and clear chest. We don't look at the pupils. We don't generally rely on the pupils as an endpoint of atropinization. We look at clear chest, heart rate more than 100, BP more than 90. Okay. So we want some heart around 110. We start off around 110 on day 1. Okay. So you start at 1.8 to 3.2 milligram. Double the dose. If you give 1.8, 1.6 now, after 5 minutes, if your endpoints are not attained, you can give 3.2. Then another 5 minutes, double, 6.4. Like that, you double the dose every 5 minutes till the endpoints are reached. Few caveats are there. These OP poisoning patients are prone for aspiration, right? Because of the low GCS, increased secretions, they are prone for aspiration. Sometimes, even after the endpoint is reached, your chest may not be clear. That is because of the aspiration and not because of the bronchoria. Okay, you have to keep a watch on that. And the reason behind one of the reasons behind why we don't look at the pupils, sometimes there can be eye splash, skin contamination, eye splash of OP toxin will be there. That will directly cause a constriction. Even after giving repeated dose of atropine, your pupils may remain constricted. Okay. Remember, atropine does not reverse the neuromuscular dysfunction and central apnea. And regarding the maintenance dose, so you have attained an atropine, you have attained the endpoints of atropinization after this much dose of atropine. So then you have to calculate the total dose, how much atropine you have given, and you have to start 10 to 20% of the 20% of that dose as an infusion. That is 10 to 20% of that total dose per hour infusion. Okay. And that you have to give it for at least 3 to 5 days. And you can titrate the atropine dose depending on the symptoms and side effects. Now, the procedure which you should do before or at least along with atropinization is catheterization, because you're giving a lot of atropine and it can cause urinary retention. And if you don't catheterize, then it will be difficult. So before giving atropine, always remember to do catheterize. And regarding pyrrolidoxime, it is a cholinesterase reactivator, and you this as you rightly pointed out, carbamates, this PAM is not needed, and it is useful in organophosphate poisoning. And organophosphate, there are two types of compound, diethyl and dimethyl. The difference is dimethyl compounds are more toxic and they age very early. The mean half-life of aging for dimethyl is roughly around 3 hours, 3.3 hours, while that of the diethyl compounds, it is around 37 hours. So if you give the PAM after the aging has set in, then there is no use. That bond is irreversible. So you have to give the PAM before the aging has set in. And again, the evidence is contradictory. Some studies, I mean, majority of the studies have not found any mortality benefit, but only one study, that was from Mumbai, I think, Pune, Pawar study. That study found mortality with the high doses of PAM, roughly around 50 gram PAM was given. The general dose which we use is 2 gram loading dose over 20 minutes, followed by 0.5 gram per hour. And you will give PAM for 7 days or till atropine is not needed for at least 24 to 48 hours. You got the point?
Yes.
If you're giving PAM, you have to start early. Evidence is not that great. You have to continue that for 7 hours, 7 days, or till atropine is not needed for 24 to 48 hours, whichever is early. Okay. And always remember to give PAM as a slow infusion over 20 minutes. Don't give a fast bolus because it itself can cause a neuromuscular weakness and it can cause respiratory arrest. And never use PAM alone without atropine. PAM cannot act at the central nervous system. So this is remember PAM. And regarding the other drugs which has a theoretical benefits, one is the magnesium. So magnesium inhibits the calcium and prevents the presynaptic release of acetylcholine. Then N-acetylcysteine, which works against oxidative stress. Then clonidine or dexmedetomidine, because it is a central alpha-2 agonist. So again, it will prevent the release of acetylcholine. So these are the magnesium, dexmedetomidine, N-acetylcysteine. These are some of the drugs which have some benefits, theoretical benefits, even though studies have not validated that. And I had asked you one question regarding the investigation which will help you in diagnosing OP poisoning. It is ideally it is RBC cholinesterase. Okay, but in general we will look at the plasma cholinesterase. In the lab we cannot do the RBC cholinesterase, but we do the plasma cholinesterase. So the plasma cholinesterase value will be, or the butyryl cholinesterase value will be reduced in organophosphate poisoning, even though the levels are not found to correlate with the severity. It doesn't mean that if the plasma cholinesterase values are very much less, that means the toxicity is severe. It doesn't mean that, but definitely in an OP poisoning, the values will be less. That is how, if you're confused, whether the patient has taken OP or not, you can send a plasma cholinesterase value. And if it is reduced, that means patient definitely has taken OP. Better than plasma cholinesterase, it is the RBC cholinesterase, but we cannot do that in lab. That's why we do plasma cholinesterase. Okay. So now he is currently on atropine 30 ml per hour, and heart rate is not improving, BP is not improving, even though other symptoms has improved. So this is atropine refractoriness. So it is defined as atropine requirement of more than 30 milligram per hour for continuous 3 hours, or a cumulative dose of 100 milligram over the first 6 hours of presentation. Okay, this is how you define atropine refractoriness. And the exact theory, reason why it is happens is not clear. Maybe some sympathetic ganglion blockade or sympathetic blockade. So the treatment is you can start or give a slow dose 1 to 2 milligrams per minute of adrenaline infusion. That will help in solving this situation. And now he becomes agitated, restless, hallucinate, and has fever spikes. This is nothing but it is atropine toxicity. Okay. And so how will you manage? You will hold the atropine for 1 hour and then restart at a lower dose, around 70% of the previous dose. You can even use glycopyrrolate. Glycopyrrolate has almost the same efficacy, but glycopyrrolate does not cross the blood-brain barrier and it does not act at the central nervous system. That is one of the limitation of glycopyrrolate. So maybe you can use usually half the dose of atropine. You can, half the dose of atropine, you can give glycopyrrolate as infusion. So now his symptoms are better, but you find this muscle weakness. That is intermediate syndrome. Okay. It is basically because of the nicotinic action, because of the action of the organ of phosphate at the nicotinic receptors, neuromuscular junction. So the point is your atropine will not be, if the patient develops intermediate syndrome, you cannot increase the dose of atropine or you cannot restore the atropine because atropine is not going to help you because atropine has no action at the neuromuscular junction or at the nicotinic receptors. The treatment is supportive. If you need to intubate, ventilate, okay, and give supportive care. After 2 to 3 weeks, the intermediate syndrome will resolve. Now, patient is better and plans to be discharged. So, what will inform the patients and bystanders or the long-term complications of OP poisoning? It is opioid-induced delayed polyneuropathy. Patients can develop polyneuropathy maybe 4 weeks after the ingestion of OP poisoning. That is known as opioid-induced delayed polyneuropathy. Patient can have numbness, tingling, again weakness. So that again the treatment is symptomatic. That is because OP inhibits another enzyme known as neuropathy target esterase. So you have to warn the patient and bystanders that patient can develop such neuropathic symptoms and treatment is supportive only. No need to worry. That will resolve by time. And another poison which mimics OP is pyrethroids, your cypermethrin. So that has almost the same similar clinical picture. And there are pesticides which contain both OP and pyrethroids. Okay. So what happens? There will be potentiation of the toxicity of both in such cases. Okay. So any clarification you need?
That's more than fine.
Okay. So you
More than
need to know the
clarified.
receptors. You need to know the receptors. You should be thorough with the receptors where OP acts. Okay.
Right.
Okay, fine. Great.
Ji.
Best wishes. Sushna?
Thank you, sir.
Hi, so thank you so much. Thank you, Dr. Kiran,
Okay,
for
thank you.
joining in.
Thank
And
you.
thank you, Dr. Prithvi.
Thank you, ma'am.
So
Thank you.
I think we are end with the short case 2. Now we'll start with the short case 1 by Dr. Mohammed Khalid. Dr. Kiran, you can stop the screen sharing if you want. Thank you, Dr. Kiran. Dr. Khalid, you can start now. Dr. Gurkinath, are you there?
Yes, ma'am, I'm there.
Oh. Dr. Khalid, we are unable to see the screen. Like you haven't shared the presentation yet.
Can you see it?
Yeah, you have to open this presentation right now. We can see the screen.
Yeah, now is it visible?
No, the presentation is not visible.
Okay, 1 minute.
If you can just stop sharing and share everything, the entire screen, then it will be easier.
Now it is visible? No.
No.
Wait a minute, just a minute. Wait a minute. Wait a minute.
Yeah. Yeah, will be.
Now is it visible?
It was visible earlier, now it is again the other thing.
Okay. Is it visible now?
Not yet. You can stop sharing right now and then start again. That will be easier.
Yeah, wait a minute. Share. Share. Yeah. Now is it visible? No.
Not yet.
Take me 1 minute. I will
You can-
stop sharing.
yeah.
I will start.
Now it's shared. And do the entire screen. That will be easier then.
Now is it visible?
Just the same thing, but the presentation is not visible.
Presentation is not visible.
Yes.
Now? No.
No, because you have to do the entire screen. We're doing it only one window.
So there's now what problem is happening?
Sir, he's sharing only one window. So instead of that, he has to choose the first option given while sharing. So the entire screen gets visible.
खालिद को क्या हुआ रहा प्रॉब्लम? आया
हाँ,
तो आ
अभी
गया.
ठीक
आया सर?
हाँ आया.
है। अब ये एनेबल कर लो तो वो इजी रहेगा
ठीक है.
और फुल स्क्रीन कर दो सर.
अभी आया सर?
हाँ, परफेक्ट.
वेट अ मिनट.
Gurkita, you are ready?
Yes, ma'am, I'm ready.
Yeah.
Perfect.
So this is your case scenario. You can read this thing.
A 29-year-old male patient presents with complaints of tingling and numbness in bilateral lower limbs since past 10 days, progressive weakness of both lower limbs since 5 days. He also complains of difficulty in breathing for past 12 hours. There is also history of bout of acute gastroenteritis 2 weeks back. Examination revealed notable power of 0/5 in bilateral lower limbs with absent knee and ankle reflexes bilaterally. Single breath count of 13. How will you approach this case? Yes, sir. Sir, this is a 29-year-old male. He has symptoms of sensory as well as motor weakness. Seems to be more peripheral symptoms rather than a central component. there is breathing difficulty from past 12 hours, so it is gradually progressive. Now it is rapid in progression, and with that there is history of gastroenteritis also. After that there was peripheral weakness that has started, and the examination has also revealed that the power in lower limbs is 0 by 5 and absent knee and ankle, but there is single breath count is very low of 13, so respiratory muscles are also involved. And sir, my diagnosis will be I will approach this case as the, neuromuscular weakness.
Okay.
Like I will try to evaluate the causes of neuromuscular weakness. Most common in this provisional diagnosis is young male gastroenteritis weakness, GB syndrome, Guillain-Barré syndrome. Number one.
Okay. Hmm.
Number two, some toxin
Okay.
that has caused weakness. Number three, there is no history of insect bite, so I will rule out tick paralysis. And since he's young and consciousness is there, so I'm ruling out brainstem stroke.
Okay. So what kind of toxins you are telling about?
Botulism toxin,
Hmm. Okay.
heavy metal toxin,
Yeah.
but they are going to be more gradual and not this histories of 10 days.
Hmm.
And now he's having respiratory, so this is it is having if it is a metal related toxicity, it
Hmm.
will have more bigger span of like month, maybe more than a month.
Okay. So
And there
most
will be
commonly,
chronic exposure to that. It is not a single exposure of metal toxin will cause this.
okay, as it was precipitated by acute gastroenteritis 2 weeks back.
Anji. Yes, yes.
So you
So
are
I'm
most probably
thinking of
diagnosed.
GB syndrome.
Yeah. Okay. Okay. So then what is GB syndrome?
Sir, GB syndrome is uh, peripheral neuromuscular weakness involving axonopathy, neuropathy. There are three types of it: acute inflammatory demyelinating polyneuropathy, where there is more of motor involvement. There is neuropathy, and if the axon is involved, axonopathy is also there. Then like that in acute motor axonal sensory AMSAN and AMAN variant,
These are the
there will
variants you are
be
speaking about.
autoantibody formations against the neuromuscular against the neurons.
Okay. Okay. So it's a acute
Auto
polyneuropathy. So it's a immune
and
mediated peripheral nerve sheath or axon destruction is there.
peripheral nerve sheath axon
Yeah.
destruction
So
due
what
to
is the
antibodies.
pathophysiology about the GB syndrome? What you're saying?
The pathophysiology is that there is molecular mimicry followed by formation of antibodies, T cells, as well as antibodies and complements against the myelin sheath, against the axons, uh, and they are ascending in nature. So it starts from peripheral weakness and progresses to central
Distal to
nerve. Not
proximal.
Yes, sir.
Distal to proximal. You mean to say.
Distal to proximal.
Yeah. Okay. So there are mainly the antibodies are directed against the myelin sheath and the axons of
Axons. Yes, sir.
neurons. Okay. It's okay. Can be preceded by the viral or bacterial illness as well.
Viral and bacterial illness followed
Okay.
by that.
Okay. So what are the variants of GBS you already told? Okay.
Yes, sir.
So the like AIDP, Aman and Amsan variant are there.
And then there are other also
Yeah, other are there. What are there?
Miller Fisher variant is there, where
Okay.
GQ1B antibody is involved.
Yeah.
There is involvement of ophthalmoplegia is there, ataxia is there, where the central nervous system also gets involved.
And one is Bickerstaff brainstem encephalitis. What is that, if you know?
Sir, it has got
Miller Fisher plus.
it, uh, Bickerstaff encephalitis. It presents like the with the with muscle with ataxia is there. The cerebellum is more involved.
Yeah, ataxia is there, and the one more thing is there. The altered confusion, altered sensorium is there. Confusion is there in
Yes.
Bickerstaff. More component is there. Okay, so good. So next, what are the clinical features, signs, and symptoms lead to make your diagnosis? What are the signs and symptoms you find in this?
Sir, absent reflexes,
Hmm?
sensory involvement, motor involvement will be there. Absence of brainstem, absence of cranial nerve involvement,
Okay.
uh,
One is
and
muscle
sign.
weakness you told. Okay.
Yes,
About the
sir.
tendon, deep tendon reflexes.
Deep tendon reflexes will be absent in
Okay.
this. There
That is
will
a
be
sensitive, 90% sensitive hallmark finding is there. Okay.
yeah, there will be there will be muscle involvement, but diaphragm will be spared.
Okay.
But in but accessory muscles will also get paralyzed. So patient will end up into hypoventilation, respiratory failure, neuromuscular weakness.
Okay. So objective muscle weakness is there, loss of DTR is there, and
Yes.
tongue weakness
Sen-
can be there, which can lead to airway compromise and all. Okay.
yes, sir.
So the rest of the symptoms like the first symptom which is there. What is the first symptom? The sensory disturbance will be there. The
Yes,
first
sir.
symptom you
Sensory will
find.
be first, then
Yeah.
motor, then respiratory.
Yeah. So paresthesia are common in that. Paresthesia is there.
Tingling, numbness will start.
Yeah.
Yes.
So which variant doesn't involve the sensation sensory part of this? Which variant?
AMAN variant,
Okay, yes, yes. Amen doesn't involve the sensation. Okay. So it's a ascending flaccid paralysis. Okay.
ascending flaccid paralysis.
Yeah. So cranial nerve involvement are mostly not there.
Yes, sir.
Okay, good. So what is dysautonomia? What do you know about this?
Sir, since nerves will be involved, autonomic nervous system will also be affected in GB syndrome. Along with flaccid paralysis, there will be autonomic disturbances. Both hypertension, tachycardia, bradycardia will be there. Salivation, lacrimation, diaphoresis, and
Okay.
then it will secretions will dry up also.
Okay.
So this can happen.
Okay. So both sympathetic and parasympathetic activation is there.
Sam,
Okay.
yes, sir.
So BP will be very labile. You mean to say that? Okay.
Yes, sir.
So how do you manage dysautonomia?
Sir, dysautonomia, sir, if the tissue perfusion is maintained
Hmm.
and there are no signs of tissue involvement, organ perfusion is all right. Other markers are leaving blood pressure alone. Other
Hmm.
markers are supporting that tissue perfusion is all right. Then blood pressure will not be targeted,
Hmm.
because there will again dysautonomia will have both the phases of BP high and BP low. So, but if there is tissue perfusion is there, then blood pressure will be targeted with fluid resuscitation and no vasopressors or epinephrine.
Okay.
And bradycardia, if it is life threatening and there is PR prolongation is there, heart block signs are there, then it will be treated.
So you should avoid beta blockers mostly if there is
Yes,
a
sir.
critical hypertension in this. Okay. Okay. So if bradycardia is persistent, what do you do there?
Sir, if bradycardia is persistent, um, sir, treat it with the anticholinergics transiently. But the main is resolution of dysautonomia should be there with the treatment of with plasma exchange and IVIG. The treatment of GB syndrome should be the first. And then dysautonomia itself will be corrected once the uh, plasma exchange is done, axonopathy is reversed,
Mhm.
and dysautonomia will get in control. Treating dysautonomia should not be the priority. Treating neuropathy and axonopathy should be the priority. Yeah.
Okay.
But if dysautonomia is due to if patient's respiratory failure is getting there, if his breathing muscle is getting compromised, then if that is the current, that is the reason why he's having bradycardia, respiratory distress, tachycardia, then first of all, airway should be the first priority.
Okay. Sure. So how do you make the diagnosis of GBS with a CSF analysis and other tests? What do you do?
Sir, for GBS diagnosis, albuminocytologic dissociation will be checked in CSF and in
What is
nerve
that
conduction study.
What is the albuminocytological dissociation?
Sir, after first week, there will be more of protein in the CSF, but the lymphocyte counts will be less. It is supposed to go one way, but it will go in that albumin will surpass the lymphocyte count. So there will be albuminocytologic dissociation. It is suggestive of that there is a axonal and demyelination injuries going on, because of which the proteins are more and lymphocytes are there in the CSF. And with that, we will
Do you see that early in the disease progression, early in the phase of the
by fourth
CPS,
day.
but CSF can be normal in that?
Yes, sir. That is why we need a nerve conduction study for this.
Okay. So, you know, what are the
Or
ganglioside serologies you told already, you have said?
Sir,
Like,
GM1, if ganglioside GM1 is there, then it is a motor axonal. It is more dangerous as per critical care point of view, because their neuromuscular patient will have severe axonopathy. Respiratory failure will be catastrophic and more faster than that of EIDP. So their GM1, if it is positive, then we should think of early intubation, because a rapid muscle progression will be there. Other are GM1 and GalNAc, GD1, GQ1. They are
okay.
in Miller Fisher.
And in EIDP, usually they are absent, ganglioside.
There are no antibodies till now of AIDP. AIDP we get more as a nerve conduction study diagnosis.
Okay.
F-wave
So
latency.
what do you know about the Brighton criteria?
No, sir.
Okay. It mostly consists of three components like clinical, then one is the investigation like CSF and the NCS study, and the third is the exclusion of the alternate diagnosis. So I'll come to that in the debriefing. Okay. So what are the features which are not consistent with GBS?
Sir, involvement of facial muscles.
Hmm.
Involvement of cranial nerves is not consistent with GBS. Diaphragm is not involved. Sensory patient will be intact. Motor and cortical functions will be intact.
Substantial asymmetry in the weakness. It should be symmetric.
It will be symmetric. I'm not sure. Asymmetric.
Sure. We'll come to it in the debriefing. Okay.
Asymmetric.
Asymmetry will rule out actually. The thing is that. Then how do you manage GBS actually in your patient? Your patient was having
Sir,
out of
his
12.
single breath count is 13. So first priority will be airway. Secure the airway. And since every second neurons are getting lost, so we will go with early plasma exchange in this case. Plasma exchange versus IVIG, but since here is it is more respiratory involvement, I would go for early plasma exchange.
Okay.
1 to 1.5 times the plasma volume, 5 cycles.
Okay. So you did your airway protection you have done, okay, because your single breath count was 13. So after that, you take the decision to intubate, na?
Yes, sir.
Then what caution you follow during intubation?
Sir, there is dysautonomia. So so induction agents will have to be guarded. Number one. Number two, there is already be dysphagia in this patient. There will already be secretions retained, so is already aspirated. So rapid avoid hyperventilation, as that can trigger further aspiration during bag mask valve ventilation. Number one. And number two, neuromuscular blocking agents short-acting neuromuscular blocking agents like atracurium should be used.
Mhm.
Rapid sequence intubation should be done rather than delayed sequence.
Okay.
Yeah.
So how do you took the decision to intubate? Are there any criteria to decide about the intubation? Any rule or any criteria?
Sir, IGRIS score is there.
Okay.
Erasmus GBS score. It takes into account brainstem involvement. It takes into account, dysphagia involvement, respiratory rate, motor. So these three criterias.
There are many criteria there, like 20, 30, 40 rule is also there.
Yeah, that is another 20, 30, 40. If the negative inspiratory force is more towards minus 30, minus 40, minus 50, then then we are on the safe side. But if it is less than minus 20, like minus 10, minus 5, then that means negative inspiratory force is less. Post vital capacity is less than 20, and 40 rule is expiratory. Expiratory pressures are if less than
Maximum
40.
expiratory pressure less than 40. And
Yes, 20, 30, 40 rule.
okay.
Other than clinical features, staccato speech, paradoxical breathing, single breath count is less, diaphoresis, and use of intercostal recession is there.
Okay. Okay. Then in GBS, IVIG and Plex both are used. So
Yes, sir.
how do you justify this thing? Which one is better and what you should go for? Anything like that?
If sir, it is a MAN variant, if it is motor axonopathy variant, where the respiratory muscle then is more severe, then it will take time. So they're giving IVIG and waiting for IVIG to come into play after 3 weeks is difficult. Where their early plasma exchange is beneficial, and that to high volume, 1 to 1.5, because we have to get rid of antibodies. And uh, if it is AIDP variant and respiratory muscles are transiently involved, if it is a gradually progressive, if you still have time on the clock, then IVIG is preferred. There are trials which have shown no benefit of other, but still the meta-analysis is supporting plasma exchange for respiratory involvement.
Okay. But IVIG is more widely available and less cumbersome, but it is expensive. So you can go for that also actually. So is there anything like the IVIG plus plasmapheresis, anything like this is available?
Yes, sir, there is, but then you have to do first plasma exchange, then do IVIG. Because if it is the other way around, then IVIG will be removed by the plasma exchange.
Yeah, but it has not shown any superiority over an individual approach.
Yes, sir.
So what is plasma exchange?
Sir, plasma exchange is exchanging the plasma volume uh, uh, with the plasma which does not have the antibodies for which the plasma exchange is done. Plasma exchange is removing plasma by its either centrifugation or membrane filter. There are two types. Either there is plasmapheresis or there is therapeutic plasma exchange. In plasmapheresis, you are just removing the plasma and you are not exchanging it with the plasma. In plasma exchange, the plasma is either being exchanged with fresh frozen plasma. The plasma is removed by either centrifugation or membrane filter. It's and uh,
Or using
in
albumin?
and or albumin.
It's a cheaper thing actually.
Yes.
Okay. What is the dose of IVIG?
Sir, 0.2 gram per kg.
It's 0.2 or
Uh,
0.4?
120 gram lump sum, 6 days, 0.2
5
gram,
days.
5 days.
Okay, it's 0.4 gram per kg per body.
0.4,
Yeah.
yes, sir, 0.2 to 0.4 gram.
Okay. What are the complications while using IVIG?
Sir, circulatory overload, hyperviscosity syndrome, uh, anaphylactic reaction,
Okay. Hmm.
uh,
AKI, thrombotic complications.
acute kidney thrombotic complications,
Okay. And what are
thrombosis,
the complications of this
plasma.
plasma exchange?
Sir, transfusion associated circulatory overload. If you are replacing with plasma, transfusion associated lung injury, hypovolemia, hypocalcemia, hypophosphatemia, dyselectrolytemia, citrate toxicity,
Okay.
acidosis because of citrate, and volume deficit, hypovolemia.
Okay. So, and now your patient is intubated. Okay. So he may require long, prolonged ventilation. Then what do you counsel the attendant? How do you counsel the attendant regarding this thing? Then what do you need?
Sir, key things to be addressed in the counseling is that patient will require prolonged intubation, and later he may develop critical illness neuromyopathy, and so there will be a time then the patient might get weaned, but he may again go from weaning failure. We may go into weaning failure. He may require tracheostomy
Okay.
and prolonged ventilation, and may further require course of IVIG in future for chronic inflammatory demyelination.
Now we can start the debriefing. Sir, Indam sir.
Yeah, please start the debriefing now.
So Khaled is taking the second short case also?
No, that the first one, the debriefing just for 10 minutes, sir. We'll do the debriefing and then we'll first. This is the second short case, sir.
Okay.
First
First
is
short
done.
case was taken by Dr. Kiran Rajagopalan.
Ajay, these are all short cases is happening.
Yes.
Wait a minute. So is it visible now?
No, the same issue. You need to show the presentation.
Yeah, I'm stopping that now. Starting the sharing. Share.
You have to do the entire screen instead of a particular window.
Wait a minute.
Yeah, perfect.
Okay. So wait a minute. Now is it okay? So your patient was a 29-year-old male patient. Okay. Like tingling and numbness in bilateral lower limb. Since past 10 days, progressive weakness of both lower limbs since 5 days. I complained of difficulty in breathing for the past 12 hours. There is also a history about acute gastroenteritis 2 back. Neuropathy, immune-mediated peripheral nerve sheath and axon destruction was there. You told about the pathophysiology, antibodies were directed in the myelin sheath or the axons of the peripheral nerves. Preceding viral or bacterial illness can be there. Then variants of GVS, you told most of the things. Okay, except for the Beaker strap component, but so you may not remember the components of those things. It's well and good if you know about this. Okay, but you told about AIDP, Aman Amson variant, and this all these variants you told. That was good. Then infectious precipitants are there, like Campylobacter geogene, Zika virus, ECMV, EBV, and other triggers like immune checkpoint inhibitors and immunization can also lead to this. So you need to know about the precipitating factors. Okay, most common is the Campylobacter geogene, which you said. Then the signs and symptoms was that objective muscle weakness was there, loss of DTR was there. That is the hallmark 90% sensitive. This is okay. The loss of DTR. Then coming to the symptoms, Paresthesia are common, you told. Okay, and Aman does not involve the sensation. You told these things also. Okay, but it's the ascending flaccid paralysis that is important, and cranial involvement, like common. Occasionally, ocular, facial, or oropharyngeal muscles are affected first. Okay, and facial weakness and ophthalmoplegia and difficulty in swallowing. Cranial involvement are common. Okay. You told about dysautonomia. That was good. Like sympathetic activation can lead to increased BP, leading to press and Takotsubo cardiomyopathy, and parasympathetic activation like bradycardia, facial flushing, and vasodilation. You told about this thing. About the management of dysautonomia, you told if hypotension is this, hypovolemia, you will correct with IV fluids, and if required, then vasopressor. In hypertension, avoid treatment unless the MAP is more than 1 TT. Avoid beta blockers. Remove the triggering factors like pain, agitation, and all. Short acting vasodilators you can use. And in bradycardia is there IV atropine and severe electrical pacing if it's severe. Okay. So then diagnosis you told about the CSF, albuminocytological dissociation you told. So high protein levels more than 45 or WBC count typically less than 10. It's there. Okay. And ganglioside serology also you said. These things you have said. Miller-Fisher variant has anti-GQ1B and AIDP doesn't have this ganglioside serology and all. And other tests for GBS, you told EMG, nerve biopsy, and the MRI. And diagnosis is mainly based on the history and examination and supplemented by the LP and electrodiagnostic information. So main is the history and the examination. So coming to that, what is required? There is a progressive weakness of more than one limb and areflexia that is required, and suggestive is progressive over days to weeks, recovery beginning to 2 to 4 weeks after cessation of progression. Cranial involvement mainly Bell's palsy, dysphagia, dysfunction will be there, absence of fever at onset, albuminocytological dissociation, and typical findings of the EMG and NCS. These are suggestive findings. So Brighton criteria, there are level 1, level 2, level 3 evidence. Brighton criteria mainly involve the clinical findings. The investigation part is the both CSF and NCS. And third is the exclusion of the alternate diagnosis. If all the three are there, level 1 evidence. Level 2 is there clinical, either CSF or NCS, and exclusion of the alternate diagnosis. And level 3 is clinical plus exclusion of alternate diagnosis. So if you are answering well, they can come to this Brighton criteria and all, or else they don't ask about this thing. Then features non-consistent with GBS is the asymmetry. Substantial asymmetry is there. Maximum weakness within 24 hours or more than 4 weeks is there. If CSF white cell count is more than 50, elevated neutrophils are there. Okay. Sensory less suggestive of focal spinal cord lesions, and bowel and bladder dysfunction are there. Severe and persistent bowel bladder dysfunction is there, or deficit localizing to the brain is there. Okay. And some pulmonary dysfunction with little no limb weakness, and these are not required. But this CSF finding and this symmetry and this sensory involvement, you need to tell about this. And the GBS management, you told that you have to secure the airway. So you need to do not delay the treatment waiting for the LP or the nerve conduction study, because you have to go to the history and the examination part and start treatment if you are suspecting GBS. Okay. And simultaneously you can go for the investigation. Management is in your patient the breath count was less than 13, so you know that there was a respiratory compromise was there, so you planned for intubation, and airway protection you have done by intubating, and neuromuscular blocker you avoided, or you can go for the low dose and avoid the depolarizing muscle relaxants like sectional choline and all. And you have gone for the RSI, rapid sequence intubation. That was a good thing. Decision to intubate was taken. Then several criteria exist, but you have told about the 20, 30, 40 and the EGRIS also you have said. Okay. So you know that the 20, 30, 40 rule, like forced vital capacity less than 20, maximum inspiratory pressure less than 30, and maximum expiratory pressure less than 40. And GVS, you told about IVIG versus Plex. They both shorten the time of recovery, but IVIG is more widely available, but it is more expensive. And any critically or hospitalized patient with new onset GBS merits treatment. Okay. So plasma exchange, you told that the exchange for the albumin or the FFP, the exchange of patient plasma with the albumin or FFP, that 200 to 250 ml of plasma per kg body weight in 5 sessions are exchanged. Okay. And the complications also you told coagulopathy, hypocalcemia, transfusion reaction. If FFP is used, angioedema, removal of certain medications can be done along with that. So that can also lead to the less efficacy of those medications which the patient is taking, and catheter related complications can be there. Okay. In IVIG, you told about the dose, that is 0.4 gram per kg per body weight daily for 5 days. Both the methods like IVIG and plasma exchange together doesn't has any superiority over the individual treatment. So mostly we avoid. But if in case you are using, you can go for plasma exchange, then you can go for the IVIG. And the complications of IVIG, you have said it was acute kidney injury, allergic reaction, and thrombotic complications and infusion related side effects. So the case is over now. Okay, thank you. Anything you want to ask? Hello.
Gurkirat?
No, ma'am. No, ma'am. Thank you, sir.
Yeah. No, you presented the case very well, Gurkirat,
Thank you, sir.
or something, but it was overall good. Okay, thank you.
Thank you, Dr. Khalid. There are
Yeah.
certain questions which are there in the chat box. If you can answer it
Where?
in the chat box, you can just write it there.
I'm answering those things. Meanwhile, you can start the next thing. I'm answering there.
Absolutely. Thank you so much.
Okay.
Thank you, Dr. Khalid.
Yeah.
So, Dr. Kuldeep, are you there? Dr. Arnav?
Yes, ma'am.
Yes. Okay.
Hello, Sudeshna ma'am, my screen is visible?
Yes, it's visible.
Yes?
You can continue. Thank
Okay,
you.
can we start?
Yes, please start.
Okay, so this long case have got two parts. The first one is community acquired pneumonia, which I am discussing, and the second part will be taken care by Dr. Kulsaurabh. We are short of time, so we will go fast. And Dr. Arnab, I think you are presenting the case. You will present both of the part. So if you know uh, answer it fast. Otherwise, we will move to the next question. Okay. Okay, sir. So this is the case scenario. 40-year-old female presents with the fever, coughs with expectoration for 7 days and worsening shortness of breath for 1 day. So if someone 40-year-old female presented to you with these clinical signs and symptoms, what will be your differential diagnosis?
Sir, as the patient presented with a cough, with fever, and with coming from a community and with shortness of breath, so my first differential diagnosis will be community acquired pneumonia. Apart
Okay.
from that, a female patient, so there can be exposure to smokes, or I will take history regarding that. So there can be acute exacerbation of COPD also if any exposure to smoke or home indoor pollutants or etc. is there. Other than that, will be exacerbation of asthma, acute asthma, and there can be mm, there can be other
Okay,
lung
fine.
pathology like
Okay. And
interstitial
then you
lung disease.
clinically examine the patients and you get these clinical features. On the examination, you get crepitations, and in the you get a chest X-ray done, and you get a right middle lobe consolidation. So, coming straight to the question, what is the definition of CAP? Answer it, please.
Sir, community-acquired pneumonia is defined as inflammation and acute consolidation of lung parenchyma due to infection.
Good.
Um,
Which is
without
acquired?
which acquired from acquired from community.
Yeah, right. So how it can be diagnosed? Answer.
Sir, it can be diagnosed by clinical examination and history, and physical examinations, then radiological examinations, and microbiological examination like
Yeah.
cultures. And
What all armamentarium you will use of the investigations to diagnose this case? Can you answer in the
sir,
can you answer
sir,
one by one from starting from the that you will send this first and then how will you go up?
yes, sir, I will send routine blood investigations. Along with that, I will send sputum samples for culture sensitivity and stains, and then radiological investigations I will do for X-ray or CT scan maybe, and mm, I can do lung ultrasound also, and uh, apart from that, sir, some urinary samples can be sent for atypical diagnosis of some pathogens like Legionella, and
Okay.
blood samples, blood cultures, and
Okay.
then sir, yes, sir,
Okay,
this
Dr.
all the
Anam,
investigation.
will you get a CT done in each and every patient?
CT, sir, no, initially, sir, X-ray, if if I can see any consolidation in X-ray, that is well enough to diagnose. CT for complicated cases or non-resolving cases, then CT scan can be done, sir, later on.
Okay, in which cases you will send the sputum gram stain and culture sensitivity? Will you send it in each and every case or some particular cases?
Um, Sir, if the patient is presenting with purulent sputum with cough, then I can send it for culture sensitivity, sir.
Okay. And
Or
you
if I'm
answered you will.
suspecting any, or if I'm suspecting any alternative diagnosis like tuberculosis to rule out, I can send it, sir.
Okay, what is the sensitivity and specificity of this sputum culture sensitivity in these cases?
Some numbers exactly, I'm not sure, sir.
Okay, no problem. You said you will send the blood culture. So you will send the blood culture in each and every case, or there are some particular indications in which you will send the blood culture.
Sir, I will send a routine baseline blood culture if the patient is getting admitted to ICU.
Okay. So what are the common pathogens which are causing CAP?
Sir, pneumococcus, that is pneumococcus followed by Haemophilus influenzae and streptococcus and staphylococcus.
Okay, and which is more common, the bacterial community acquired pneumonia or the viral one?
So bacterial is more common compared to viral.
Okay, can you enumerate some of the causes of the virus-induced pneumonia?
Yes, sir. Influenza A and B, then respiratory syncytial virus, adenovirus, then human metapneumovirus, then SARS-CoV virus.
Yeah, very good. Can you enumerate some of the causes of atypical pneumonia?
Yes, sir. Chlamydia, Legionella, and Mycoplasma.
Good. What are the risk factors which predisposes to this community acquired pneumonia?
Sir, risk factor like age, more than 65 years. Then comorbidities like diabetes or other comorbidities, immunosuppressions. Then, sir, like uh, pre-existing lung disease like structural lung disease and other states like immunosuppression state like diabetic patients or patients on renal replacement therapies. So these patients are more prone, sir.
Okay, some medications which predispose to it.
Sir, medications means if the patient is on steroids or if the patient is on any uh, immunosuppressions medications like post liver transplant or
Yeah.
post kidney transplant patients.
Okay, good. So what are the typical clinical features of this pneumonia, community-acquired pneumonia?
Uh, Clinical features, sir, patient will present with cough, chest pain can be there, sir, cough with expectorations, then fever and shortness of breath, and tachypneic, respiratory exertions, generalized weakness. Apart from that, some CNS symptoms can be present in severe cases like confusion, altered sensorium, and patient can, in severe cases, patient can present with shock and multi-organ failure, sir.
Yeah, these all features are present in the immunocompetent patients. Yeah. Okay.
Yes, sir.
So which if the patient is presented to you, you are asked to come and see whether this patient need to be admitted in the ICU or in the ward or to be sent back to the home. Which score you gonna use?
Sir, I can use PSI score, that is pneumonia severity index score. Uh, uh, Based on that stage, different stages are there, and stage 4 and stage 5 of PSI will require ICU admission. Then I can use CARB 65 score, and it also have different scoring. And stage like CARB 4 and 5 will be for ICU admission. Then, sir, other scores like for CARB 65, I can use CRB 65 also, and other like, sir, IDS ATS coding is there, which also
Out of these
it-
two, CARB 65 and pneumonia severity index PSI, which is also called as PORT, which one will you use? Which is preferred?
sir,
And why?
I will sir, CARB 65 has a sir, CARB 65 has more sensitivity, and PSI has more specificity.
Okay. So when you will got to know, or when you can decide that this patient particularly needs ICU admission?
Sir, if the patient is a severe community acquired pneumonia, that is, patient is presenting with shock or respiratory distress, then definitely will need ICU admission. Or if PSI staging 4 or 5 or CARB 65 4 or 5 will require ICU admission, sir, based on that.
Okay. So if the patient does not require ICU admission or inside hospitalization, how can you manage the patient on the OPD basis? What all antibiotics will you use?
Sir, based on, if the patient is managed on OPD basis, then, sir, I will prefer the um, uh, if I'm suspecting atypical infection, I will add a macrolide along with, sir, along with yeah, third generation cephalosporins.
Okay. And what is the what empirical antibiotic therapy will you use if the patient is hospitalized? How will you approach?
Sir, if my patient is hospitalized, then my antibiotic therapy will be based on our local antibiogram of and local sorry. If the patient is admitted, sir, then my policy will be third generation cephalosporins or carbapenems plus a macrolide antibiotic, sir, I will add if I'm suspecting atypical infection. And Yes, sir.
Okay,
And
will
if the patient is having,
the
and sir, if I'm suspecting risk factor of community acquired MRSA infection, then I will add MRSA coverage. And if the patient is having high risk for pseudomonal, then I will add pseudomonal coverage also.
Okay, good. So, will you add the anaerobic coverage in each and every patients with the risk factor for aspiration? Yes or no? And why?
Sir, for severe community acquired pneumonia, if I'm adding a carbapenem, if I'm starting with a carbapenem, then I may not add a anaerobic infection, as it may cover many of the anaerobic pathogens, sir.
But if suppose you are starting with Tazact, then
Sir, Tazact also have some of the anaerobic coverage, but um,
okay, you will in which cases you will add the anaerobic coverage? Okay, no problem. Moving to the next question. What is the typical duration of antibiotic therapy?
sir, antibiotic therapy will be uh, 5 to 7 days, sir, based on the
And in which
clinical
cases,
condition of the patient.
yeah, and in which cases you need longer duration?
Sir, if it is a community acquired MRSA or pseudomonas, may need a longer duration of therapy, sir. Especially for community acquired if MRSA, then it will require longer duration of therapy.
So do any biomarker have any role in the management or treatment or antibiotic de-escalation in this CAP?
So biomarkers are there, but not very routinely used. But we can use procalcitonin serial assay to de-escalate, to specially de-escalate antibiotics. Serial
Okay,
procalcitonin assay.
okay, does it have any effect over the outcome and mortality?
Sir, it hasn't showed significant difference on the mortality, but it has shown effect on uses of antibiotics, less uses of antibiotics, sir.
Okay. So does NIV have any role in these patients' management?
Sir, NIV can be used, but based on the patient's clinical condition, I have to take, sir, judgment if my patient is not improving with NIV, or if the patient is having severe respiratory distress, or if patient's PF ratio is less than 150, then I will not prefer, sir, NIV. But in milder case, I can go with NIV. And if patient have previous structural lung disease or COPD history, then in milder case, I can go with NIV.
So if if the patient presented you with CAP and now he lands up in sepsis, how will you progress? How will you approach?
Sir, I will send the routine investigations and blood cultures as well as respiratory sample cultures, and I will start with empirical antibiotics, and I will assess the patient. First of all, I will assess the patient for airway breathing and circulation. If my patient is airway is compromised or patient is having significant work of breathing, then I will first secure the airway. If a patient is requiring that, after that I will target the hemodynamics. If my patient is hemodynamically unstable, then I will first stabilize the hemodynamics and vasopressors if requiring. Then, sir, I will start empirical antibiotics, fluid resuscitations, and fluid resuscitation based on hemodynamic monitoring. And then I will start with antibiotics, and accordingly, sir, I will progress.
Okay. So what are the complications of this community acquired pneumonia?
Sir, complications like patient can develop pleural effusion, and
Yeah.
patient can present to heart failure from community acquired pneumonia. Patient can go into ARDS, and patient can present with empyema, lung abscess, and non-resolving pneumonia, sir.
Okay, right. Good. So what supportive measures besides from treating cap you will take when the patient is in ICU?
Sir, supportive measures, sir, I will strictly follow hand hygienes, and I will then, sir, I will start nutrition. I will start general faster beats for all
Yeah,
for
right.
these
I'm
patients,
basically asking this
and
only, the how fast bit. Okay. Yeah.
yes, yes, sir.
So what is the role of steroids in community acquired pneumonia?
Sir, the role of steroid is controversial in community-acquired pneumonia, but based on recent few trials like Cape Cod study, it can be started, sir. And if the patient is further going into ARDS, then we can think of starting steroids, sir.
Yeah, it's a gray zone and very difficult
Yes,
to
sir.
answer. Okay. So you have treated the patient and the patient is getting discharged. So how will you advise your patient to prevent the cap?
Uh, Sir, first of all, based on the I will take a proper history from the patient, that whether how his home hygiene is, how the well sanitized area he is staying, or he like any factors like pigeons or any pets in his or her
Okay, okay, Dr. Arnab, what all immunizations you will suggest to your patient?
yes, yes, sir. For so like influenza vaccinations, I can seasonal influenza vaccination I can suggest to my patient, and
Yeah,
like for pneumococcal vaccine, sir. I can
yeah.
if the patient is elderly, I can suggest for pneumococcal vaccines.
Okay, thank you, Dr. Arnab. Now I'm starting
Thank you,
with
sir.
the debriefing session. My screen is visible, Sudeshna ma'am? Sudeshna ma'am,
Yes.
screen is visible? Okay. So the definition is pneumonia is it's an inflammation and consolidation of lung tissue due to infectious agents, which is acquired outside the hospital. This is community acquired pneumonia. And how it's diagnosed? It's a clinical diagnosis and clinically suspected with symptoms. And we can use the radiology also. So chest X-ray showing new infiltrates. And we can use sputum and blood cultures if severe. So what all investigations you will send in the diagnosis? Dr. Arnab have answered this question very well. So it is chest X-ray. We suggest chest X-ray in almost each and every patient. CT, he have answered right. To the non-resolving cases or the patient with who have any structural diseases of the lungs. The sputum and blood culture we will discuss in a while. And AVG and BAL and urinary antigen. In the urinary antigen, for this, there are two bacteria. One is the Legionella and the other one is pneumococcal. So we will not prescribe this urinary antigen in each and every case if the patient have traveled to a particular endemic zone
Kuldeep,
or there is a common outbreak of Legionella,
Dr.
then we can
Kuldeep,
prescribe this.
Dr. Kuldeep, your screen is
Yes,
not
sir.
moving. Sorry to interrupt in between, but your screen is not moving.
Not now?
You have to share, the debriefing screen is not showing. You are still on the screen, the question answer presentation.
Okay.
You can stop sharing and then reshare again.
Now it's visible.
Yes.
Visible. It's moving.
Yeah,
Yes,
it's
yes,
moving. Visible.
it's moving.
So what is the definition of CAP? It's the pneumonia. It's the pneumonia, inflammation and consolidation of lung tissue due to infectious agent, and it's acquired outside the hospital. And how it's gonna be diagnosed? So it's a clinical diagnosis, clinically suspected with symptoms only, and then we can use the chest X-ray, or we can add our diagnosis with these sputum and blood cultures. So what all investigations we can send? So Dr. Arnav answered it very well. The chest X-ray, CT, we will not get it done in each and every case. So if a patient have a particular non-resolving pneumonia, or we suspect any other diagnosis, or the patient have a structural lung disease, then we can order CT. Sputum and blood culture we will discuss in a while, ABG, and then BAL, and urinary antigens for Legionella and pneumococcal, they have a sensitivity and specificity around 70 to 80%, and we will not order urinary antigen in each and every cases. For the Legionella, if the patient is have traveled to a particular region with the endemic Legionella, or there is a community outbreak, then we can order these, otherwise not. And the PCR, the gram stain and culture of secretions. So this is not for the OPD patients as per the IDSA. Then the gram stain and culture of secretion should be sent for the patient with severe CAF which are hospitalized, or the patient is intubated, or if the patient have any past history of MRSA or Pseudomonas aeruginosa, and if the patient gives history that within 30 to 90 days the patient have received the parenteral antibiotics. Only in these cases we will send patient is hospitalized to be MR with the is and tuberculosis not
Recording in
genetic
progress.
predispositions. The life and environment factors, smoking and alcoholism, ventilation, socioeconomic status, and contact with children, indoor and outdoor pollution. So what all comorbidities predispose to it are the previous pneumonia, it's a predisposing factor, antibiotic exposure, hospitalization, COPD, obstructive sleep apnea, asthma, heart failure, and diabetes mellitus. Some medication and
Recording in
how we
progress.
gonna use it, how we gonna implement it, and what it gonna predict. Even if we do not able to answer the each and every component of the score, then there is no problem. But we should able to answer these questions. So which one is preferred and why? So both were developed to use as a prognostic model in immunocompetent patients with pneumonia, using patient demographics and clinical variables to predict 30-day mortality. Dr. Anna answered that we want to use curve 65, but no, PSI identify larger proportion of patients at risk and it is preferred. So when is ICU admission required for CAP? So if a patient is having septic shock or shock requiring vasopressors, respiratory failure needing mechanical ventilation, multi-organ failure, or any other comorbidity which predisposes him to get admitted to the ICU. And if the patient does not have any of these, and we want to know that patient require ICU admission or not, then we can use these scores, ATS 2000, IDSA ATS score, SmartCob. Among these 2 and 3 are the preferred one. In both of them, IDSA ATS is the preferred score. So what are the so these are the recommendations of IDSA ATS for the treatment of patient on the OPD basis. So healthy patients with no use of antimicrobials within last 3 months, macrolide. And with these comorbidities, we can give the patient respiratory fluoroquinolone or a beta-lactam with a macrolide. So if the patient is admitted or hospitalized or in the ICU, then how we gonna approach? So it is divided into two: in patients with non-severe pneumonia and in patients with severe pneumonia. In patients with non-severe pneumonia, we can go with a beta-lactam plus a macrolide, like one piperacillin tazobactam plus clarithromycin or respiratory fluoroquinolone monotherapy. If the patient has a prior MRSA or Pseudomonas history, then we have to add the coverage accordingly. If the patient have inpatient admission and the pneumonia is severe, then we will go with beta-lactam plus macrolide or beta-lactam plus respiratory fluoroquinolones. So what are the so should we add the anaerobic coverage in each and every patient with aspiration risk factors? The answer is no, we should not, as ATS and ESICM task force suggest prescribing only standard CAP treatment. And indications for anaerobic cover are if the patient has putrid discharge, empyema, lung abscess, and necrotizing pneumonia. Otherwise, not. Duration of antibiotic therapy, it's usually for 5 to 7 days. And it was found that when we compared the duration of 5 to 7 with the 8 to 10 days, no difference in outcome was found. So longer duration is required in case of cavities, lung abscess, tissue necrosis, legionella. In this case, we need therapy of 14 days, and Staph aureus therapy required is around 4 weeks. So role of biomarkers, there is an armamentarium of biomarkers available. And this is the AUC under the graph of each and every biomarker. But what we commonly use is procalcitonin because it is extensively studied. So it have got role in differentiating the infection from bacterial and viral. It also, as Dr. Arnav answered, it can be used to reduce the duration of antibiotic therapy. And it was found that it have no effect over the outcome or the mortality. So does NIV have any role in community-acquired pneumonia? May help in selected cases, but early intubation is preferred if respiratory failure worsens. So how is capillary sepsis managed? It is like any other sepsis: early antibiotics, fluid resuscitation, vasopressors, and source control. So what are the complications of CAP? Pleural effusion, empyema, lung abscess, respiratory failure, sepsis, and multi-organ failure. So what supportive measures are essential in CAP management? So besides treating the community-acquired pneumonia, we have to treat the patient as a whole, and we gonna stick to hug fast bed here, like oxygen therapy, fluids, anticoagulation, nutrition, glycemic control. So what is the role of corticosteroids in CAP? It's controversial, it's a gray zone, difficult to answer, but ATNS and IDSA are against the use, while European Respiratory Society, ESICM, ESMID, and ALID supports the use of steroids in CAP. ATS 2019 is against the use of steroids. ESICM have prescribed a dose of methylprednisolone 0.5 mg per kg PD for 5 days if shock is present. So how can we prevent the CAP? So vaccination, influenza vaccination have a role in this. There are 2 types of vaccine available: inactivated influenza vaccine and intranasal live attenuated influenza vaccine. Pneumococcal role is not very clearly defined, but there are 2 types of vaccine: we can give depending upon the patient set, and then smoking cessation and hand hygiene. Thank you. Any question?
I think you can type the question in the
Okay,
chat box.
now Dr. Kulswara will take over the next part, ARDS. Thank you.
Hi, my screen is visible. Is my screen is visible?
Yes. You just have
So,
to do full screen.
do it. Give me a second.
हेलो
Is my screen visible?
यस सर
Yes, sir.
अच्छा ये तो उसका है
So Prithviraj, your case will be after this. This will be done by Dr. Mohan.
Yes. So, good evening, Dr. Arnab. So
Good evening, sir.
it has been a very marathon kind of thing for you. So we'll try to go a bit fast so that we can cover as many as topics. And I should say it that this is just a practice session, and the focus behind this program is to let you know what all topics that are being asked, that are supposed to be asked, and how do we answer them. Okay, so first of all, we'll go through these questions a bit fast, and whatever you know about these questions, tell us. And thereafter, debriefing में, I'll be sharing the sample answer in a bit faster pattern so that other topics are also given adequate time. So this is the add-on topic apart from CAP. Usually either it's CAP or ARDS. Sometimes the case of CAP reaches ARDS. So we have joined this two topics. So case scenario in front of you.
Yes, sir. A CAP patient deteriorates despite antibiotic and oxygen therapy and develops worsening hypoxia requiring mechanical ventilation. And ABG showing ABG showing hypoxemic respiratory failure, that is PaO2 reaching 55 in spite of 100% FiO2, and there is bilateral diffuse infiltrate. So my patient has. Yes,
now
sir.
we are discussing about ARDS. Okay. What is
Yes,
the
sir.
Berlin definition of ARDS?
So Berlin definition focuses on four things, starting with timing. So that is within 1 week of onset of a clinical insult or a new worsening of lung pathology within 1 week, and chest radiograph showing bilateral opacities not fully explained by by effusion or any cardiac origin, and severity, that is oxygenation, that is PF ratio mild between 200 to 300 with PEEP of 5, and moderate, that is 100 to 200 with PEEP of 5, and severe, that is PF ratio less than 100 with PEEP of more than 5 centimeter of water.
Okay. What are the common causes of ARDS, and which causes of ARDS is associated with worse prognosis?
Common causes of ARDS. So common causes of ARDS can be infective causes or non-infective causes. Among infective causes, sir, it can be due to any pneumonia presenting worsening to ARDS, or any other infection other than lung site, like pancreatitis, which is triggering ARDS, and non-infective causes like, sir, chest trauma or any smoke inhalation injury or poisoning. These are the this can present to ARDS. And which causes ARDS is associated with worse prognosis? Sir, non-pathological, non-lung pathology causes are having worse prognosis.
Okay. What is the hallmark pathology of ARDS?
Sir, ARDS in pathophysiology primarily consists of three phases. That's it. First is exudative phase, followed by proliferative phase and fibrotic phase. Then fibrotic phase. And
okay. How is the severity of ARDS classified?
Sir, severity is classified based on PF ratio, that is mild, moderate, and severe. With PF ratio between 200 to 300, when PF more than 5 is mild, 100 to 200 moderate, and less than 100 is severe. And based on saturation SF ratio, that is saturation and FI2 ratio, it can also be classified. That is 265 to 315 is mild. 149 to 235 is moderate, and less than 149 is severe.
Okay.
Without PEEP.
Okay. Enumerate management strategies of ARDS.
Sir, management strategy will be a ventilatory strategy. Ventilatory strategy will be ventilatory strategy can be non-invasive and invasive. Non-invasive on mild to moderate cases and invasive in severe cases. That is PF ratio above PF ratio less than 150 severe, and above 150 can be tried with non-invasive. But if patient is worsening, we'll need ventilatory strategy.
So this
And
can have many kind of answers. We'll discuss it in the debriefing session. Okay.
Yes,
What is baby lung concept and how do we relate it clinically in ARDS?
Sir, baby lung concept was proposed by Gattinoni et al. And the concept is that due to ARDS, as it is a heterogeneous pathology, so a portion of the lung is not actively involving in the gas exchange. So the portion of the lung that is which is having a compliance and which is participating in gas exchange is of much lower percentage compared to the whole lung. So if and the lung which is non-compliant, if we are targeting that with if we are taking that in consideration, so it will more cause harm to the patient rather than any benefit with the ventilation strategy. So we have to give low tidal volume based on the viable lung tissue that is present, so we don't cause harm to the non-viable lung tissue.
What are ARDS related ventilator associated lung injuries?
Sir, ARDS ventilator associated lung injury can be classified into different types, like volute trauma, that is with more volume. If the patient is if the more volume is causing harm, that is volute trauma. Then, sir, atelect trauma, that is cyclical opening and closing of the alveoli causing atelect trauma. Then, sir, barotrauma, which is the pressure, excessive pressure causing ventilator lung injury. And, sir, then ergotrauma, which is the overall power causing the lung injury. And biotrauma, sir.
Okay, wonderful.
That is the,
what are the ventilatory strategies in ARDS and its supporting evidences?
So ventilatory strategies will be high PEEP and low tidal volume strategy, and the supporting evidence is like first it was from the we get from ARMA trial, where 6 ml per kg was compared with 12 ml per kg, and then, sir, subsequently ARDS NET protocol, we have got that with high PEEP and low FiO2. Then, sir, subsequent other evidence like.
Okay, we'll discuss it. You are right, partly right, but yes, at times, at few of the times, these landmark trials, the examiners ask them very specifically. We'll discuss it. Okay, lung protective ventilation, ARTSNet, this is same. Adverse consequences of lung protective ventilation, if you can name some.
Sir, that is permissive hypercapnia.
Yes.
Yes, and respiratory acidosis. Then it causing, sir, cerebral vasoconstriction, and hypoxemic respiratory failure, and
Sure. What are the rescue therapies in ventilation in an ARDS patient?
Sir, rescue therapies are like prone ventilation and ECMO and high frequency oscillation ventilation, but it hasn't shown any benefit. And
Okay.
ECOR, sir, we can try.
Okay. I'm giving you less time. Don't take it in a you know many things. If you get adequate time, you may answer. But because of the time restriction, we should cover more of the topics. What is the physiological basis of titrating PEEP?
Sir, we basically target the optimal PEEP. So if the PEEP is not optimum, so maximal PEEP will cause harm and minimal PEEP will also cause harm. So we need to target the optimal PEEP. Maximum PEEP will cause hemodynamic disturbances, and low PEEP will not prevent the arterial trauma, sir. So we have to target the optimal PEEP based on and maintain the hemodynamics of the patient.
What do we mean by open lung technique, and discuss recruitment maneuvers?
Sir, open lung technique is preventing the cyclical opening and closing of alveoli. So we have to maintain a PEEP throughout the time, and with a high PEEP and low tidal volume, so that we are not causing any ventilator induced lung injury. And recruitment maneuvers, sir, we can have different kind of recruitment maneuver, that is incremental PEEP, decremental PEEP, CPAP method, and we can titrate the PEEP from our flow volume loop also, sir, and stress index.
Okay. Role of neuromuscular blockade and supporting evidences.
Sir, sir, in accurate, sir, some noise disturbances. Yes, sir. In accuracy trial, sir, it has shown that they have some. It have some benefit of neurovascular blockade, but in Rose trial, we have seen that not significant mortality benefit is there, and intermittent neuromuscular blockage is preferred compared to continuous, sir.
Wonderful. So now also your patient doesn't improve. Now what do we do?
Sir,
Despite all the ventilatory changes, low tidal volume, with
so I will go for
slow management.
So I will go for prone ventilation.
Okay,
And
wonderful.
if my patient is not improving with prone ventilation, then I can go for extracorporeal support, sir.
Okay. When should prone position be used in ARDS?
Sir, early prone is preferred, sir. If patient is not improving and PF ratio less than severe patients, PF ratio less than 150, early proning and prolonged proning. Prolonged proning, sir.
Supporting evidence for proning.
Sir, Prusaber trial, in where it has shown that at least 17 hours of proning per day, and early proning has significant benefit and significant mortality benefit.
And any detailed analysis of Prusaber trial you can comment upon?
Sir, say early pruning and, sir, prolonged pruning of more than 17 hours, and
any specific reason of Prusaber trial being successful?
No, sir, I cannot recall it at this moment.
Okay, not an issue. Indications, contraindications, specifically contraindications of prone positioning.
So specific absolute contraindication will be spinal injury and cervical cord injury, spinal injury, or patient is on severe shock. And relative contraindications like can be of pregnancy, open chest trauma, facial trauma, then, sir, burn patient.
Okay. What are the adjunct therapies in severe ARDS?
Sir, adjunct therapies we can like inhalation nitric oxides and sir, like methylene blue in shock if the patient is in shock, or like inhalation nitric oxides, or
Role of steroids in ARDS?
Role of steroids, sir. Yes, sir. Steroids can be tried, sir. Steroids.
So, do we have any existing evidence for steroids in ARDS?
Yes, sir. There are many trials. Specifically, sir, early steroids in the early phase of ARDS, it has shown role and hydrocortisone infusion.
Okay. Do you know any supporting scientific data that supports using steroid in ARDS?
Yes, sir. Early use of early steroids benefit had been shown by Meduri trial, and apart from that, sir, in COVID ARDS, we have seen uh, recovery trials, sir, have shown benefit in COVID ARDS, and DEXA ARDS, sir, trial has shown a benefit also in steroids.
Fluid management in ARDS?
So fluid management will be guided by my hemodynamics parameter, and it will be tailored according to the patient's clinical condition and need. So, and over resuscitation, sir, should not be done.
Avoided. It's avoided. So we can better
Yes,
say
sir.
conservative fluid therapy, है
Yes, sir, and
Okay.
conservative fluid strategy based on the hemodynamics and patient's clinical condition.
Poor prognostic indicators in ARDS?
Sir, persistent plateau pressures more than 7 days, and persistent low APF ratio with high FiO2 ratios persisting more than 7 days, and non-responding patients with worsening hemodynamics.
Potential complications of ARDS?
So multi-organ failure and AKI and heart failure, and
these are acute complications, है ना? Long-term complications.
So lung fibrosis and and
neuromuscular weakness.
Neuromuscular weakness is critical illness, neuropathy.
Yes. है ना? Long-term
Yes,
sequence.
sir.
We must know something about driving pressures also.
Yes, sir. So driving pressure is plateau pressure minus PEEP.
Okay. So how do we use it?
Sir, we target a driving pressure of less than 16.
Okay. And how do we use it clinically? So basically on titrating PEEP, if we are able to reduce the driving pressures, okay, so that means that PEEP, in escalation of PEEP is somewhere useful. In brief, we talk about it. Okay.
Okay.
Okay. So let's now quickly go through the debriefing part. Most of the answers have been answered by Dr. Arnab, and I shall try to do a quick debriefing.
Kulsarav, Dr. Pandit has also joined. You can take him for some opinion.
Yes, sir. Yes, sir. Sure. Sir, rather, I would love if sir can only go through the all the management and part.
I think Dr. Pandit sir is here.
I'm here. I have just joined. I only listening to your last complications of ARDS is the only thing when I joined actually. So I don't know what discussion has happened before. You continue those. I am around. If you need any help, any opinion, I will be happy to pitch in. And if there is anything I feel needs to be added, I will interrupt you if you don't mind. Is that okay?
Yes, sir. It would be pleasure to everybody, sir.
Thank you. Thank you.
Thank you. Thank you. So we were discussing a patient, CAP, who wasn't and ended up in ARDS. So, Berlin definition of ARDS: it is acute onset less than 1 week with bilateral lung infiltrates, PF ratio less than 300, and there's no cardiogenic cause. At the same time, we must know the difference between the AECC definition of 1994, what is the Kigali modification, and what's the new 2023 global definition. So, difference with 1994 AECC definition is timing that is not specified in AECC. Chest imaging, CT has been also added in the Berlin criteria. Then PF ratio, it has been mild, moderate, severe in the current Berlin definition. There was no mention of PEEP in the AECC definition, and origin of edema was defined by pulmonary artery wedge pressure. And whereas it has been mentioned that the edema, origin of edema not explained by cardiac failure comes into as a criteria of definition in Berlin definition. Okay, so at the same time, we must know the new 2023 definition. What are the common causes of ARDS? So it is divided into two parts, pulmonary and non-pulmonary, that is systemic. Pneumonia, aspiration, lung contusion, inhalational injury, reperfusion injury, near drowning, fat embolism. And in systemic causes, we have sepsis, multisystem trauma, TRALI, acute pancreatitis, and cardiopulmonary bypass. Definitely the non-pulmonary causes are the worst causes of ARDS. What is the hallmark pathophysiology of ARDS? So definitely there are three phases of ARDS. But if this question is answered in one line, it has to be answered that increased alveolar capillary permeability leading to non-cardiogenic pulmonary edema is the hallmark pathophysiology of ARDS. How is the severity of ARDS classified? This was answered very rightly by Dr. Arnab, so we should not go much into this. But yes, we must at the same time mention the PEEP or CPAP of 5 centimeter of water in all the divisions. Enumerate management strategies of ARDS. This can be answered in different patterns, but yes, it has to be answered in a meticulous manner. If we go haphazard, so definitely we waste a lot of time on this single question. And as per my personal experience, we have to go as many as questions to get better marks. So I have done it in this manner: standard of care and rescue strategies. This is the ventilatory management, and followed by the non-ventilatory management. That includes the fast hug bed, nutrition, glycemic control, thromboprophylaxis, each and everything. So standard of care includes low tidal volume with PEEP titration, with PEEP ratio of less than 30 and driving pressures of less than 15, 16. Mention of transpulmonary pressure and mechanical power. These are two newer and very upcoming concepts. If we do mention these concepts in a rightly manner and right time, definitely they add to some add-on marks to us. Sir, I would request Rahul sir to please mention, to please throw some highlight on this.
I completely agree with you, Saurabh. I think it's not enough now to just talk about tidal volume, PEEP and PLAT. You need to talk about driving pressure, and you need to talk about your transpulmonary pressure and mechanical power. Especially mechanical power is now something which, in combination with driving pressure, a lot of research is going on that. Obviously, none of the trials have shown any mortality benefit. Mechanical power is the amount of power which is transmitted by the machine to the lungs, to the respiratory system overall. And it's not difficult to calculate it for the sake of calculation, but I believe the next modes which are going to come on the new ventilators will actually deliver mechanical power to it, to as a figure for it. And the magic number there is around 12 joules. Anything less than 12 joules is good. Anything more than 12 joules is actually causing harm to the patient. So mechanical power, definitely yes. Transpulmonary pressure remains a challenge to measure. That's the biggest problem, because the invasive measurement which needs to happen, or a very specialized ventilator which you will have to buy. It is not something as simple as mechanical power, which can be derived from the existing mechanical ventilator numbers which it captures. So it is going to be a challenge to bring it into day-to-day clinical practice. But I see driving pressure and mechanical power probably driving the research forward now. And when the next set of good papers will come out, you will probably see a practice changing papers using combination of mechanical power and driving pressure. So you definitely need to talk about it, and you need to know about it. I completely agree with your table, and your rescue table, rescue strategy also is pretty good. I don't think anything additional in the rescue strategy needs to be talked about. They should know a little bit more about ECMO, If you're okay, I can talk a word about ECMO right now. Is that all right,
Yes, sir.
Kaustubh? You want to talk?
No, sir. Please do.
So in ECMO, it can't be just described as a rescue strategy. It can actually be a treatment modality for a certain group of patients. I believe they should be the students should be able to categorize which patients would benefit from ECMO and which patients probably will not benefit from ECMO. That's the first important thing to categorize. So if you have a patient who is within 7 days to 2 weeks of onset of illness, I believe those patients are the ones who may actually benefit from ECMO. Anybody who stayed on the ventilator for more than 2 weeks and we try to put those patients on rescue ECMO, generally don't do well. And we've got now enough evidence to say that earlier the better. That doesn't mean that you don't even give them a option of proning and you straight away go on ECMO. You should be talking about proning as a first strategy before you decide to go on ECMO. So they should actually have a good proning attempt before you decide to put them on ECMO. Proning again does not remain now like only rescue strategy as such. Proning is probably the best recruitment maneuver which you can give to your patients. So it's you can see that you've not put recruitment maneuvers there as the first thing. You put proning as the first thing, and that's because it's the best recruitment maneuver which you can give. Many of us have almost given away the practice of recruiting patients on a mechanical ventilator in supine position. We prone them and we see that the recruitment automatically happens. The second point about ECMO which I want to make is they should be aware that what is a VA ECMO and what is a VV ECMO and what are the indications. So generally in ARDS, VV ECMO will form the importance. So they should know where the blood is actually drawn from and where the blood is returned from. So for the sake of understanding, when you are using VV ECMO, you need to return the blood as close to the heart as possible and draw the blood as away from the heart as possible. So your sucking cannula is usually into the IVC and much below the hepatic part of IVC, as well as your return cannula is as close to the right atrium or your IVC or your SVC as close to the right atrium as possible. So that's your return cannula. And the VA ECMO is exactly the opposite. You suck the blood as close to the heart as possible so that you actually empty the right ventricle as much as you can, and you return it into the arterial circulation either through a femoral artery or you return it into the central circulation through a open ECMO or a aortic cannula been placed by opening the chest and doing it. These are the only 2 or 3 comments. I think rest of it you have actually summarized it quite well. Over to you.
Thank you, sir. So what is the next question was what is the baby lung concept and how do we rate it clinically in ARDS? So baby lung concept was it says that ARDS lung has normal and unaerated, partially aerated normal segments inflate easily and the unaerated segments distend poorly and have high pressure and slow response. So normal lung segments may be overinflated when ventilated with additional tidal volume. So we need to strategize the ventilatory settings as in a way so that the normal aerated lung does not get injured. So next question was what is the ventilatory associated lung injury? So they were rightly mentioned by Dr. Arnab, valvular trauma, barotrauma, atelector trauma, biotrauma, and another is ergotrauma. What are the ventilatory strategies in ARDS and its supporting evidences? So objective is to adequately ventilation of compliant alveoli without causing valvular trauma and barotrauma. Strategies include small tidal volume that is 4 to 6 ml per kg with acceptable respiratory rate of 30 per minute with permissive hypercapnia that is PCO2 of 80 mm of Hg and with peep rate of less than 30 centimeter of water. So what is the evidence for lung protective ventilation? That is the low tidal volume. This is a very landmark trial, ARDS net protocol that showed us with the mortality benefit of 31 versus 39.8% of mortality with tidal volume of 6 into 12 ml per kg. And this is also known as the ARMAR trial. It also mentions about the mortality benefit. There was another question about the adverse consequences of lung protective ventilation that says that it rents the patient into hypercapnia at few of the times, and at the same time, because of the low tidal volumes, patient is provided with low tidal volumes, so the patient sometimes ends up into uh, uncomfort or asynchrony that leads to more of sedation. Higher levels of sedation are required. So, any addition to whatever I have said?
So one thing I would like to add, if you could go back to your slide where you showed 30 centimeters of water, the previous, this one. Not sorry, not this one. Yeah. Yes, this one. So P plat of 30 centimeters comes from your ARMA trial, which obviously is the landmark trial for ArtsNet protocol. Now the students can add a little bit and collect some extra brownie points if they say that nowadays they want to limit it to 27, because there are good number of studies which say that at 30 centimeters you may have a RV dysfunction secondary to ARDS, and if you keep the P plat below 27, the RV dysfunction is incidence of RV dysfunction secondary to ARDS is much lesser. So that's the only point I would like to add. Everything else I think you've covered fantastically well.
Thank you, sir. So, what are the rescue therapies? PEEP, titration of PEEP, recruitment maneuvers, neuromuscular blockade, and prone ventilation. Definitely, prone should have been on the top of this list, as mentioned. Inhaled nitric oxide, APRV mode, and lastly, ECMO and echo. What is the physiological basis of titration of PEEP? So, it prevents atelectotrauma, reduces intrapulmonary shunt, improves oxygenation, reduces dynamic tidal strain and stress applied to the lung, reduces mechanical stress. We must, at the same time, we must know the methods to titrate the PEEP. Here are the, it is another slide mentioning the utility of PEEP. These are the methods to titrate the PEEP. Sir, I would like to your interference in this. The student must know 2-3 points. The landmark pattern of titrating PEEP. There's a lot of confusion. Well, I was also giving the exam. I also was not very uh, specific to method of titration of PEEP. I would like you to please mention it.
So I think you've actually you've already mentioned the PEEP FiO2 table, which is, I think, the most easiest one to actually use and titrate. And with the proning, it has made a real difference in terms of how you have to titrate PEEP nowadays. It's not difficult at all. If you have to really set the PEEP right, I think it's the lowest inflection point on the pressure volume curve is probably the best one to do that, because the CT guided PEEPs or arbitrarily setting PEEPs is not going to help you into doing anything more strategically correct. Staircase method, I believe, is very difficult now. It is probably not going to help you, especially if you're going to prone the patient. So really, the best way to do the PEEP is actually use the lowest inflection point. Now, if you are going to have end-tidal CO2, you already put that slide on. Okay, good. So you can have the lowest arterial minus end-tidal CO2 gradient, which will essentially tell you that the PEEP is so optimal that the dead space is minimal. And that is, again, I think, a second way of doing it. And of course, if you have a transpulmonary pressure, that probably is the best part of having an invasive monitor, where you put a balloon, esophageal balloon manometer, and you use your pleural pressure and your esophageal pressure as a surrogate for the pleural pressure, esophageal pressure surrogate for the pleural pressure, and you then titrate your PEEP, so that at the end of the expiration, the transpulmonary pressure is somewhere below 10 up to 0. I think that's the best. These are the only two ways in which I could tell you how to titrate the PEEP if you have to titrate. But trust me now, proning the patient makes it very, very easy. PEEP titration using FiO2 PEEP table of the ArtsNet table and then prone the patient has made a life really simple for an intensivist. Gone are the days when you were giving them very high PEEP with staircase method or arbitrary PEEP of 14 or 15. Right now, you're looking at these things and actually adjusting your PEEP nicely. The second thing which I do in my clinical practice is I look at the RV function. If my right ventricular function is going bad, if I'm actually causing RV to dilate using my high PEEP, then I think even with the lowest inflection point, I might go a little lower to keep my PEEP so that my RV function is adequate and not compromised on the ventilatory settings that I have got. So we should not use too many of these methods. I think 2 or 3 methods are fine. PEEP FiO2 table, combining it with prone, lowest inflection point, using your transpulmonary pressure. If you can put a esophageal manometer, which is a very difficult one, not many people will be able to achieve it, but using the lowest arterial minus end tidal CO2 gradient, that's probably the best, which will actually tell you that the dead space is minimum. Now in ARDS, using that dead space is minimal is fine, as long as you are uh, ventilating that patient at that particular point. It's a very dynamic thing. As the alveoli keep on opening, the dead space may also keep on changing, because that's what you're doing. You're recruiting the patient regularly. So you will have to sort of do that lowest arterial minus end tidal CO2 gradient quite frequently. And the trials which have looked at it have not gone as one point discussion on that. They have looked at multiple points. Perhaps every 4 hourly, 6 hourly, you will have to look to set this PEEP and titrate this PEEP regularly with that, which nobody does nowadays. So I believe this is the best way to actually titrate the PEEP.
So about open lung approach, it is using of transiently high transpulmonary pressures to reopen lung units, followed by sufficient PEEP to maintain them open. It uses a recruitment maneuver to open the lung units, followed by high PEEP to keep them open. Few of the recruitment maneuvers are, as Sir said, that now clinically, though we are not using them very often, but definitely to answer them in questions, we use these kind of methods, that series of high tidal volume ventilators, use of CPAP for 30 to 40 seconds, CT scan method and USG method. We must know the names of these methods. Before doing the recruitment methods, we must have a look at the patient's hemodynamics, and we must check if there is no pneumothorax or pneumomediastinum, PO2 by PO2s, and because with these recruitment maneuvers, there may be a fall of saturation transiently. So we must have a look on the PCO2 and compliance, and adequate sedation should be there. While discussing the role of neuromuscular blockade and supporting evidences, there are 2 trials. One is ACUVUS and one is ROSE. The findings of both the trials are a bit contradictory, but definitely ACUVUS trial supports the usage of neuromuscular blockade, whereas ROSE trial doesn't. We should know why is the difference existing. This is the table that shows a difference between both the trials. You may take a screenshot of this. Let's not go into depth. Let's take the summary out of it. So this says why is the difference between both the trials, because prone position was used less in ROSE trial as compared to the ACUVUS trial. There was no optimization of minute volume and sedation prior to entry into ROSE trial. Patients recruited in early phases of illness in case of ROSE trial. There was increased use of PEEP in ROSE trial. Patients most likely which were responding to the neuromuscular blockade were not entered into the ROSE trial, and there was increased sedation in control arm of ACUVUS trial. So now, till now, we have used neuromuscular blockade. We have used ventilatory strategies. Patient is not improving. Now what to do? We are now talking about the prone positioning. Okay, the physiology of prone positioning and the indications. So it is recommended in moderate to severe ARDS, that is PaO2, FiO2 less than 150, to improve oxygenation. It improves ventilation perfusion mismatching, promotes more homogeneous lung inflation. It enhances lung recruitment. It opens collapsed dorsal alveoli, improving aeration and gas exchange. So we have talked about it. The mechanism behind this is it reduces compression by the heart and abdomen, and it also facilitates the secretion of the secretions drainage. So while we are talking about prone positioning and the physiology behind this, I suggest you to remember all the points, not to miss any of them. because each one holds its own importance. Homogeneity of ventilation, dorsal drainage, dorsal ventilation of lung. It is one of the very landmark thing that we are doing in ARDS. So it is expected out of a student that once it is a landmark thing, so all the physiological advantages of prone positioning must be mentioned. So talking about Prosever trial and reasons for it being successful. So this is Prosever trial. You may take a screenshot of this. This showed a benefit of mortality benefit of 16 versus 33. It is prolonged proning, that is for 16 hours proning and 8 hours of supine position. And what was the reason of its success is because there were many trials, there were many studies before the Prosever trial in 2016 that were doing the proning, but none of them showed any kind of benefit. So what were the reasons for its success? It is early intervention, that is within 36 hours of ARDS, most appropriate patients, that is 12 to 24 hours within the stabilization period, and proportion of timing spent in proning was very adequately selected. That is the prolonged one, proning, that is 16 hours. Before this, it was either 24 hours or maybe 8 to 12 hours. And another thing that was very much reasoning for the success of this trial was 27 centers with more than 5 years experience of proning in the participated in this trial. So with this experience, there was a huge success for this landmark trial. Sir, any addition to this?
Sorry, did you ask me something?
Sir, anything additional?
No, I think you covered it. No, nothing absolutely.
Thank you, sir. What are the adjunct therapies in severe ARDS? Neuromuscular blockade, prone positioning, inhaled nitric oxide, ECMO in refractory cases. Talking about role of steroids in ARDS, there have been multiple studies using
Can I
steroids in ARDS.
add one point called Saurabh? So a lot of the times, no, people have a lot of hesitation in proning. This may be not an exam related question altogether, but I think you may be asked. And that hesitation in proning is because of hemodynamic instability. Trust me, it's not that bad to actually even prone patients who are requiring vasopressors to keep the blood pressure up in moderate to high doses as well. Of course, you need to have a lot of people to support that proning process so that it is done as quickly and as swiftly as possible. At the same time, there are not too many shakes and moves for the patient, not too many disconnections. But you can even prone a relatively high vasopressor dependent patient also. So don't think that as a contraindication. Examiners might just ask you that, definitely.
Yes, sir. So there have been, talking about steroids in ARDS, they have shown mortality benefits. They have shown more ventilatory-free days, improved oxygenation. Low dose of corticosteroids have been showing advantages. It has been shown that early use of steroids have been suggested for in ARDS. It has questionable impact on viral pneumonias except COVID-19. So these are the studies of usage of steroids. Few of them have supported, few of them have not supported, but this is the current status of steroids in ARDS. To mention, definitely Meduri et al. Recovery trial and DEXA ARDS are good to mention as evidence. Talking about fluid management in ARDS, we must mention about the conservative fluid therapy supported by FACT trial. What are the trials of ECMO and their utility? Sir has given a good highlight about ECMO, but yes, as an examinee, we must know the trials for ECMO. One is the Caesar trial and one is alveolar trial. We must know the results and what were the conclusions of the trial. Poor prognostic indicators in ARDS. These kind of questions can be answered in many ways, but yes, it is always right and better to answer it in a very specific manner. Definitely high PO2 PF ratio, but these are very specific answers, that age, severity of hypoxia, higher driving pressures, and multi-organ failure. We have answered every spectrum in these four sentences, these four phrases. What is permissive hypercapnia and why it is used? Permissive hypercapnia is a ventilatory strategy that allows higher level of carbon dioxide in the blood. It is done by reducing tidal volumes and ventilating pressures to minimize breathing. It protects against valve trauma, and it improves lung compliances. It also promotes hemodynamic stability. It reduces inflammatory response, enhances oxygenation. What are the potential complications of ARDS? Valve trauma, VAP, fibrosis, and prolonged ICU stay, and ICU-acquired weakness. Long-term sequelae, pulmonary fibrosis, neuromuscular weakness, cognitive impairment. So, driving pressures, it needs a special mention, and mechanical power also. It is PEEP VAT minus PEEP, cutoff value is 15. Each centimeter increase in driving pressure causes 5% increase in mortality. We must know the utility of driving pressure in the clinical scenario while we are titrating the PEEP. As I mentioned while I was asking the question, on increasing the PEEP, we are increasing the driving pressure. That means increased PEEP has no utility for the patient. It doesn't cause any kind of opening of the airway. Rather, it is increasing the airway pressures. So these are few trials associated with PEEP and low tidal volume. You can take a screenshot of this. These are few topics that are good to know while we are discussing about ARDS. We have discussed many of them, but a few of them may have been left because of the limited time period. You definitely can take a screenshot of these coming 3 to 4 slides. Ventilatory management, clinical presentation, and diagnosis. We have covered almost many of them, but still a part may have been left. So I've mentioned it in this format. Over from my side, sir. Over to Arindam sir and Rahul Pandit sir.
I think very nice. I don't have anything to add. We sort of discussed it all anyways. I think special consideration pregnancy and ARDS is interesting. Did you discuss about this pregnancy and ARDS?
Sir, no. In this case, no, because we gave a clinical scenario.
Sure. Okay. I believe a lot of people have doubts about this, though there is no clinical trial and it can never be a clinical trial as such to discuss about pregnancy and ARDS because all these patients are automatically excluded from any clinical trial. But it makes a lot of sense if you have a patient who is near term to go ahead and do a delivery at a cesarean section in the ICU if you have to. And trust me, the ventilation just becomes easy. In my last 25 years, I've done it 3 times, once in Australia, twice in India, where we've actually done a cesarean section in the ICU on a patient who was close to 34-35 weeks and who had come with severe ARDS. And the moment we delivered the patient, after 10-15 minutes, the FiO2 became we could decrease the FiO2, the ventilation became easy, the tidal volume was very easy to actually ventilate. The problem is second trimester, where the uterus is big enough to push the diaphragm, but obviously you're not having comfort in delivering the baby at that time. But remember, if you are in the third trimester, closing to 34-35 weeks, where the baby viability would be there, do not hesitate to suggest and discuss with your gynecologist, with your obstetrician colleague, that delivery is probably going to save the mother's life. Remember, mother's life is the most important thing which you have to take care of. Thanks, Arindam. Over to you.
I think what is remaining, Sudeshna? Only one long case, and Dr. Paras is also here. The two, this analytics of the research paper is also here, right?
Yes. So right now, long case 2 will be taken by Dr. Abhishek and Dr. Abhishek Roy.
Now, I think let me ask Dr. Paras. He may or may not have a name. Dr. Paras, are you on board?
Yeah, I'm around.
Okay, so will you take the way quickly?
Yeah, that's fine. I'm happy either way. If you want to do long case or do literature review, I'm okay with that. Should we do the literature?
Let's do one literature, long
Yeah.
case, and then A.
No problem.
You go, no. Because Dr. Pandit is also here. He will join
Yes.
on the literature A.
No problem.
Okay.
Great. So who is doing the first one? I'll display my screen.
Dr. Arnab, are you there?
Yes,
Are you
ma'am.
ready for the first literature review?
Yes, ma'am.
Thank you so much.
Fine.
Sir, are you having a difficulty?
Yes, I'm having difficulty. Can you display?
Yes, sir. Give me a minute's time. I'll just
Okay.
come to you.
Have we paused or what's happening?
The problem in displaying the screen from my side.
Okay.
So we are sharing in a minute. Just give you 30 seconds.
Not yet.
So you just have to say next and we'll go to the next slide.
Yeah. So Arnab, you are doing the first literature review.
Yes, sir.
Yeah. Have you gone through this article, hydrocortisone in severe community acquired pneumonia, published in NEJM, March 23?
Yes, sir.
Okay, good. Next slide, please. Okay, so can you tell me what was the primary objective of the study and how does it contribute to existing literature on the use of hydrocortisone in community acquired pneumonia?
So the primary objective was to see whether the use of hydrocortisone compared to placebo reduce a 28-day mortality in patients of community-acquired pneumonia.
Mm-hmm.
And
yeah, what was the existing literature and how it made any difference in?
like the existing literature, like previous trials, like Meduri trial showed that no 60-day mortality benefit with use of methylprednisolone in CAP. So with this trial, they wanted to see if there is any mortality benefit with hydrocortisone.
Mm-hmm. Mm-hmm. Yeah. Okay. Then what were the key inclusion and exclusion criteria for patient selection for this trial?
So the inclusion criteria, like age more than 18 years and patients admitted to ICU and community acquired pneumonia patients diagnosed with cough pudendal sputum, and dyspnea, and focal radiological findings in chest X-ray or CT scan, and severe disease was defined by at least one, like PSI score more than 130, and FiO2 requirement more than 0.5 or PF ratio less than 300,
Yeah.
and patient required at least one dose of antibiotics.
Okay.
And the exclusion criteria, like, sir, more than 7 days of antibiotics and influenza positive patients, and pregnant patients were excluded, and other patients like fungal infection or any active TB patients were excluded, and patients on shock at the time requiring vasopressors were excluded.
Okay, good. Then what were the primary and secondary outcome those that were measured in this trial, and whether they are consistent with the previous randomized control trial?
Sir, the primary outcome was death by 28 days they have seen in hydrocortisone group versus placebo. And the hydrocortisone group has a lesser death, that is 6.2% compared to 11.9% in the placebo group. And that and it was a significant difference, sir, with p-value of 0.006.
Yeah.
And their secondary outcomes were, sir, like they compared hydrocortisone with placebo, and sir, there were less deaths in the hydrocortisone group, and endotracheal intubation was less in the hydrocortisone group, that is 18 versus 30%, and vasopressors requirement were also less.
Yeah. Any sorry. And whether these results were consistent with the previous literature?
Sir, previous literature was like, as I said, like with methylprednisolone, sir, didn't show any mortality benefit like this trial, sir.
Okay. So based on this trial, what may be the mechanism or pathophysiology that may have changed the patient significant difference in the mortality benefit? Why do you think, what was the pathophysiological mechanism that or potential mechanism that contributed to better results?
So they treated the patient with steroid in early introduction of steroids compared to late phases in of the disease may have given a benefit to their patients.
Yeah.
Because they introduced early steroid to the patients, early phase of the disease.
Okay. And what do you think the limitations of this trial? And do you think this is you can generalize or you externally validate this, and whether you will change your practice and routine, like you will use steroid in a patients with a severe community acquired pneumonia?
Sir, like first of all this, though it was a multi-centric trial, but it was primarily done on all the centers of France. So it is a not a multinational. It is a uninational. The study was done only on France.
Very good.
So it may not be portraying a picture like all over the world with different. They haven't include all over the world of different phenotypic and genotypic peoples. So it may differ in that perspective. And second of all, sir, because they started the trial pre-COVID era, and in between, sir, they have to change their inclusion criteria, not inclusion criteria, but they have to change based because COVID was there. So there was some changes regarding that, sir, because after that they did a subset of other patient who was there. So it was a mixed kind of situation due to COVID at that situation. And the second thing was that microbiological investigation was not standardized. Pathogen identifications were not very standardized in their trial. So based on that also there was some differences. So
Yeah.
I will look forward other trials, including multinational trials and with more homogeneous, more heterogeneous population to give a external validation before introducing this finding in my clinical practice, sir.
Okay. No, good. I think that finishes the question. I'll probably go through now just debriefing. So I think you answered most of the questions quite well. You have gone through the trial and critically evaluated the trial. So as you correctly mentioned, the primary objective of the trial, and they were looking for a reduction of around 5.5% reduction in the this one. They expected 27% mortality in a control group and 20.5 mortality in a steroid arm, hydrocortisone arm. Based on the previous trial, there were 7-8 randomized controls, but small single-center trial and few meta-analysis, 2 meta-analysis. Those were showing a differing results. One was showing benefit, one was showing no benefit. So based on the previous literature, they decided to look for, they did the power calculation. Power calculation is a amount of number of patients required to show the difference in the outcome. That is how they base the figure, showing the 25% reduction in the mortality from 27 to 20.5. With the 80% of a power and some loss of follower. Based on that, they decided 1,200 patients will be required to recruit in this trial to show the difference in the outcome. You correctly mentioned inclusion and exclusion criteria. So that is that was correct answer. The primary secondary outcome, you said correctly, primary secondary outcome 90 days, and they looked at the ventilation days and few more things. So I think you looked at that, but I think usually when you do the power calculation, you do the power calculation based on your primary outcome. So secondary outcomes, those numbers may not be enough to show calculated based on the patients recruited. So you can't extrapolate the result, but yes, it did show reduction in the endotracheal intubation, reduction in the use of NIV. So they started, as you said correctly, started steroids early, and that is what the previous studies have shown. Early steroids have shown because of the anti-inflammatory effect. So that was a potential mechanisms, the anti-inflammatory effect, and then improvement in the gas exchange and reduction in the need of ventilation and improvement in the mortality. Limitations of the trial, as you correctly mentioned, limitations of the trial, that it was done in France, but in multi-center, but single country. So it is difficult in the other population, other different healthcare systems. So you can't extrapolate into the other healthcare systems. The similar results. So you need to do another trial, either you are set up or you need to look at that. Again, you correctly pointed out that microbiology, almost 45% patients did not have appropriate microbiology or negative cultures. So there was no standardization was done. But most important problem for this trial, which I see, that they had initially planned 1,200 patients recruitment. They were doing interim analysis at the end of 400 patients, 800 patients, and then final analysis was planned. At the end of 800 patients, when they did the second interim analysis, they found that there was a significant difference which was meeting their target. That is why they decided to stop the trial. That is again a red flag for me. To start stopping the trial early may not, they should have just continued, and they should have just recruited all 1,200 patients and showed the same outcome. Probably I would have accepted more this one. I'll probably accept this with a pinch of salt where they have stopped the trial. We have burnt our fingers previously with activated protein C PROVASE trial, which was stopped early. Similar, this one showed significant benefit. They stopped early. They changed the protocol previously in the similar trial. So again, you have to take these trials with a pinch of salt because they stopped the trial early at 800 mark rather than achieving the target of 1200. So they haven't completed. Again, their power calculation has become wrong because initially they predicted mortality of 27% and 20.5. But if you look at their mortality is very low, 6% versus 12%, 6.2 to 12%, or even hospital mortality was 9% versus 14.7. So they recruited patients with those who were not very sick. So they recruited less sicker patients in this trial. So mortality is less. So severity of illness was low. So again, whether recruiting moderate to or very severe community acquired pneumonia, whether you would have got the similar result or different result or better result, I don't know the answer. But again, so that is one thing, that their patients were sicker. Second, power calculation had changed because they calculated their number of patients required to show the benefit was 27 versus 20.5. Here mortality was much less. So your power calculation had changed. You probably, again, that doesn't give all the answers. Okay, so I'll probably still use steroids in a very moderate to severe patients, but probably generalizability, or there are some concerns. So again, you have to decide. If pneumonia with shock, probably I will use pneumonia, only pneumonia. I'll probably will have to have a second thought. Risk benefit I will have to look at before using the steroids. Yeah, now you did well.
Thank you, Dr. Paras. Pandit sir,
Dr. Pandit, you have any comments?
No, I think Paras has covered it quite well. I don't think there's any comments there to make or add anything. And the conclusion also was well constructed by Dr. Paras. So very nice. Nothing else to add.
Thank you, sir. Thank you.
So can we take the long case Q right now?
Share my screen?
Yeah. Someone doesn't stop sharing right now.
Is my screen visible? Who is presenting?
Yes. Dr. Krishna Shah.
Okay. So just a short disclaimer. Today's class, whatever was allotted, is already running late. So total within 30 minutes, I'd like to wrap up the entire case as well as the whatever discussion I have. And I would like to tell you that I attended one preclinical exams in CMC Vellore, where I got a lot of points in how to approach an exam, especially from practical point of view. So I'll be giving you some tips. It's not a lecture, so I'm not going in depth of the individual concepts and all. I hope that you have gone through the case. So shall I start?
Yes, sir.
Yeah. So please, so my first question is, describe your case. Opening statement, describe your case.
Sir, case summary.
Okay, so this is the case summary.
36-year-old was on 235. So 1 second, sir. Can I open in my?
Yeah, please do it. Yeah. I hope that it was given to you, at least an hour before the presentation.
Sir, yeah. Sir, yeah, 36-year-old. As the case summary. Sir, 36-year-old male by profession, labor, with an history of alcohol abuse, came to the ER with an history of fever, cough, and progressive SOB, X-ray showing left lower zone consolidation. The patient was initially managed conservatively On the day 5, the patient have a raised bilirubin as a raised INR with coagulopathy with mucosal bleed, hypotension of BP of 100 by 45 and arterial ammonia of 235 micromole per liter. Following this, the patient had a drop in sensorium, for which the drop in GCS and sensorium, the patient was intubated and the antibiotic was started. On the previous history, the patient have a history of decompensation with upper GI bleed followed by ligation and on a prophylaxis of carvedilol tablet. Known case of hepatitis B positive, not on any treatment. Currently day 8 of ICU, on ventilator, vasopressors, steroids, urine output of 30 to 40 ml per hour for last 6 hours. The patient also have an ascites.
Okay. Now the first thing, describe your case.
Sir, so this is a 36-year-old male with a background of chronic liver disease, the etiology being the alcohol, admitted now in a state of acute on chronic renal failure.
Liver failure. Okay.
Acute on chronic liver failure preceded by an acute decompensation, and most probably the cause of decompensation being the lower respiratory tract infection. The patient is currently is on ventilator and having AKI and having a decreased urine output and vasopressors with steroids.
Okay. I'll come to the next patient. So I'll add up to whatever you lack in the later on. So chief complaints you have already described. History of presenting illness, if you have gone through whatever I've sent. So do you have anything extra to add on to whatever you said? Supposedly you are describing a patient. You have a patient and in your front. You are describing to the examiner. So what extra history would you obtain? So tell in few important things.
In particular, in this patient, I will have a history of from when the patient was having chronic liver disease. First, the second, the cause of the chronic liver disease is tooth. Is the any admission for HE or recent hospital admission, and I will also take the history about the fever and the cough history and the lower what is showing in the X-ray, the lower zone consolidation, and also any comorbidities if the patient is having like any cardiac comorbidities or diabetes or hypertension. These all histories I will take.
Okay. So any significant background history you already mentioned. So I will skip this question because the background history is the history of bleed and all that we have already summarized. So this is the background history. So this is provided that he had a drinking habit of say 250 ml of vodka per day. He also had some history of sexual promiscuity. So either of the alcohol or the hepatitis B could be contributory factor. Other than that, there is some history of deprivation of sleep at night. Took alcohol for 5 days prior to admission. So this is the background. He was also on tablet carvedilol. What I would want to ask you is that among this, what is the importance of having a history of deprivation of sleep at night or altered sleep behavior?
So this points to the Western Heaven HE grade 1 for hepatic encephalopathy. The disturbed sleep is the criteria.
Okay. Right. So history of right now we have some background history of this is the history of presenting illness per se, where you have history of CAP. Basically, patient had history of fever, purulent sputum, and all those things. Gradually progressive shortness of breath, and then he was admitted to the ICU.
Yes.
So this is actually in the course which should not be here, but it's added. A few things are added. Now I'd like to ask you that. So what is your primary diagnosis, provisional diagnosis, based on the history?
So based on the history, the provisional diagnosis is that acute on chronic liver failure, the etiology most likely is the community acquired pneumonia or an LRTI, and
okay. So along with that, you might add that he has a septic shock. Along with he has AKI. So this is part of the elaborating the primary thing. But provisional diagnosis ACLF should have been fine. Okay, nicely summarized. Now, what are the differential diagnosis in this case?
so the differential diagnosis is so if decompensated liver disease can also be there, and if there was no history of CLD, we can also suspect of acute liver failure. So as the history of CLD is already there,
Okay.
but
Not
and
much of a differential per se. You can say that the infection could be a differential diagnosis, severe tropical illness, etc. But per se here, there are no other probable, definite differentials. Okay. Now, you examine the patient. Now, supposedly the patient is in front of you. Now they say, okay, describe the patient's general physical exam findings. Now, you describe the general physical findings. Just imagine that you have a patient with, this is just some clues, the patient has this nail findings, the skin, and this is one X-ray, which will obviously you will come afterwards. So describe the patient.
so as I am looking into an chronic liver disease patient, the patient will be a bit cachectic, with a tense distended abdomen due to the presence of ascites, and with peripheral edema, and also there will be from in the eye there will be there may be presence of jaundice or icterus, and there may be the signs of raised portal hypertension, like presence of dilated vessels around the umbilicus, dilated vessels in the upper limb, suggestive of portal hypertension, spider nevi, or those are the signs of chronic liver disease. There will be nail changes, whitening of nails. There may be clubbing also, if there is a history of some carcinoma in the liver. Breast engorgement, gynecomastia can be there for the chronic liver disease.
At a patient. So that's the important point. This I'll again summarize later on. You're looking at a patient. So it's already mentioned that patient is on ventilator, vasopressor. So you have to look at those few things also.
Okay, right? Sir. Now I was looking at ER. I was thinking of the ER. Yes, sir. For the patient, I will look into the first the lines and the catheters. What are in the patient? Whether first I will see to the GCS whether the patient is on any sedation or not. I will assess the GCS score in the patient. Then I will look into the lines and the catheter. And as the patient is intubated, I will look into the ventilatory settings at what FiO2 and the ventilatory settings the patient is in. And I will also assess any source of infection visibly seen in the patient, which can be a source of infection and can cause a decompensation like abscess or any skin infection. I will look into and after looking and auscultate the chest, and will listen to the chest for any additional findings, and collaborate with the X-ray. And also I will look into what feeding the patient is getting, the motion, the urine output of the patient, and cultures, available cultures.
Move on to the next part. Yes, so I'll get it. I mean, you have covered all the points, but it was a bit haphazard. So those things you have to put in line, in sequence. So this thing is done. I mean, this I'll again come to the while discussing. Okay. So what extra things will you see? I mean, any systemic examination that you want to focus on?
Sir, abdominal examination and
Okay. Any other system other than abdomen?
abdomen, respiratory system, and
Okay, these two are-
cardiovascular and central nervous system.
Okay. Now looking at the next, any lab findings that you'll be asking or you will be noticing, laboratory findings.
So in this patient, I will be looking into the two thing in the laboratory finding. One is the creatinine, one is the INR for the diagnosing the patient for ACLF. Also, I will be looking into the TLC for looking into that whether the patient is suffering for sepsis or not. I will send the respective cultures before starting the antibiotics. I will also do an ECG and also look for an echo for the cardiac function of the patient. But so as you asked, the laboratory findings mainly is the TLC, creatinine, electrolytes, and INR and bilirubin.
Okay. That should be any particular imaging that you want to focus?
Ultrasound, sir, USG abdomen.
Okay, USG abdomen and chest both.
Yes.
Okay, so this summarizes still the point of general physical examination, basic lab findings, and so up till things. So again, now what are the findings in this patient which suggest a diagnosis of acute and chronic liver failure?
Yes, sir. The acute and chronic liver failure is basically acute decompensation of chronic liver disease along with the presence of organ failure leading to short-term mortality. The presence of organ failure which was there in the patient, one is the HE grade is more than in the range of 3 and 4, which suggests the organ failure. The INR was 5.4 and the BP, the patient was requiring vasopressors and the patient was hypotensive. PF ratio was not known to me and creatinine was also not known to me in the case summary.
Okay.
So the organ failure in the background of decompensated liver disease suggests the diagnosis of ACLF according to the score.
Okay. So what is cirrhosis of liver? And if you get a patient with an history of alcohol uptake, what findings, especially what findings and what any particular thing or any questionnaire is there to assess those patients? And what is portal hypertension?
Sir, cirrhosis is basically chronic inflammation followed by fibrosis of the liver parenchyma, leading to the destruction of the architecture of the liver, leading to the formation of micro and macro nodules. And this fibrosis ultimately narrows down the portal vessels within the liver, which ultimately causes the structural changes. And also due to this, there is retention, RAS system activation, which causes functional changes. So both structural and functional changes lead to the portal hypertension. The portal hypertension is the increase in the BP. BP means, pressure within the portal system. Basically, what we measure is the hepatoportal gradient, HVPG, hepatic vein portal vein gradient. So if it's normal 3 to 5, more than 10 is clinically significant portal hypertension. In case of finding related to the alcohol-related cirrhosis, my concern will be to the two things. One is the amount of alcohol intake taken by the patient, which is at the cirrhotic dose or not, and for how much time he was taking, and what particular alcohol, the concentration of alcohol he was taking. And number 3 will be to differentiate between whether the patient is in alcohol hepatitis or in ACLD, ACLF, or that much.
Okay. Any finding, I mean, skin finding, anything in the general physical examination because of alcohol, purely because of alcohol? You have already described the serotic findings, few of them in your general physical exam. Purely because of alcohol, can you have anything? Okay, I'll move on to the next question. So, what is decompensated liver disease? So, decompensated chronic liver disease, DCLD.
Sir, decompensated chronic liver disease is defined by the presence of chronic liver disease followed by the presence of any one of the following: ascites, GI bleed, hepatic encephalopathy. These three are mainly described. In somewhere it is described HRS or jaundice.
Good, very good. So now comes to the individual part. So this patient has ascites. Okay. So how will you manage this ascites? First of all, you tell me how will you manage in the terms of will you investigate this ascites, and then further on, if the ascites, what medical management would you do, and in case of refractory ascites, what you can do?
Yes, sir. For patient presenting with primarily for the first admission with the ascites, I will always investigate for the cause of the ascites, why the patient is having ascites with an USG. If not found, then with an upper GI endoscopy followed by a CT scan, contrast-enhanced CT scan. I will also tap the ascites to look into whether
only for ascites you don't need an endoscopy or a CT scan. No, it's for ascites you were saying. This is only for ascites.
Okay, means sir, sometimes chronic liver disease become very query. So presence of a varus also signifies.
Presence of SBP, obviously there is a potential for a UGI bleed, and if you suspect that you might need an endoscopy, that is a separate aspect. But
Okay,
here first you describe what particularly
as it is, sir, I will do a tapping. I will look into the SAG or the serum albumin gradient, ascitic albumin gradient, and the total protein and the total count of the ascitic fluid and the neutrophil count. And if some other pathologies are suspected, then I will look for them.
What is the importance of measuring total protein here?
Total protein is seen, sir, if the SAG is less than 1.1, then the total protein is seen. The total protein, if greater than 2.5, then it signifies post-sinusoidal cause of ascites.
Okay, next.
Next, sir, and sir, one is the cause of the ascites and the characterization of the ascites. For the management of the ascites, I will start with the control of sodium intake or the salt intake, and I will start with the fluid intake restriction, and along with the starting of diuretics. Diuretics two are used. One is furosemide, starting at a 40 mg per day, and spironolactone is also start 50 to 100 mg per day. Sir, and along with that, I will start carvedilol or the alpha beta blocker as the patient has already decompensated. That means the portal hypertension is more than 10 and the patient has chance of further decompensation. So I will start a carvedilol at a dose of 3.125 initial starting.
You mentioned about carvedilol and you mentioned about diuretics and all those, but in this patient, before starting a diuretics, would you like to rule out something before starting diuretics? And second question is, in this patient, so this is a general practice, general management. In this patient, is these two therapies can be given? I mean, can we give diuretic to this patient directly or give beta blocker in this patient?
So at present, the condition of the patient, as the patient has already decompensated, as in the ACLF, we will surely withhold the beta blockers and the diuretics. We will not, because as the patient has a chance of HRS, we will go for the volume expansion with albumin. So, but in general, for the treatment of ascites, we use.
Yes, so this is a point to be noted that when you are mentioning, you mentioned that for general purpose or general management purpose, this is the line of treatment.
Yes.
For this patient, we cannot do this and this, so we have to go accordingly. So now, other than that, anything else that you want to do here? Like supposedly the fluid keeps on accumulating, patient has an intra-abdominal hypertension, which is already mentioned, I think, in one part, grade 1 hypertension. Anything else you can do? Would you do a single point tapping, or would you consider something else in this case? I'm saying.
So I can do a LVP, a large volume paracentesis, in the patient with a drain in situ. And
Yes. Okay. Anyway, do you know about the definition of refractory ascites?
yes, sir. Refractory ascites is the ascites accumulating again within the 24 hours or more than 3 times a year. It is classified into diuretic resistant and diuretic refractory. Diuretic resistance, where high dose of diuretics is used and the ascites is still there. Refractory is where the use of diuretics to the highest dose cannot be done due to the side effects of using the diuretics.
Okay. What is the definition of spontaneous bacterial peritonitis?
The spontaneous bacterial peritonitis is defined by the presence of polymorphonuclear leukocytes or neutrophil greater than 250 per cubic millimeter with a culture positive ascites.
Okay. You don't need always a culture positive. You don't need always. It's a PMN more than 250, and you're expected to get a single culture positive, single organism.
Single
But
organism.
you might not have a culture positive. So that's not a mandatory thing. But
Okay,
yes,
sir.
250 is the thing that has to be remembered. Yes. Now, and what is the background? What is the most important thing to remember?
Is a background of a cirrhosis. A patient is having a
Cirrhosis and
background
high
of
SAG ascites. High SAG.
high SAG ascites. Yes.
Right.
Okay.
Now, would you
Yes.
transfuse the patient? Supposedly the patient's hemoglobin is 6.5. Would you transfuse? And if you suspect that patient is having some bleed, how will you give your blood products in this patient?
So first of all, regarding the PRBC or the RBC transfusion, my target will be, if the patient is not having any cardiac comorbidities, the target will be 7 gram per DL. If the patient is having some sort of cardiac comorbidities and the patient is not actively bleeding, then my target will be 9 gram per DL. And for regarding INR transfusion, we generally don't do transfusion in this patient. Still not the patient is bleeding actively. And if the patient is bleeding actively, we go for an viscoelastic test or TEG in our institution, and according to the TEG, we give the blood products.
Okay. So okay. So can you give factor 7? It's kind of an update question, but since you're answering well, can you take factor 7 or Novo 7? Comes in the name of Novo 7. Can you give it to this kind of patients?
Sir, I have used PCC Octaplex, not Novo 7.
Okay. No issues. So now coming to this relating to the AKI. So what is HRS as per the recent definition, and how will you manage AKI here?
Yes, sir. Hepatorenal syndrome, as per the recent definition in 2024, it has been classified into HRS AKD and HRS CKD, among which the HRS AKI and AKD. The HRS AKI has been defined increase as like KDIGO AKI definition, increase of 0.3 mg per DL of creatinine within 48 hours, or more than 50% rise of creatinine within 7 days. And if this
which of the subtypes of HRS 1 and 2, which is more severe or prognostically worse?
HRS 1.
Yes, good. Now, how will you manage AKI? So, what are just mention the main management strategies here?
So first of all, managing AKI, all AKI in the cirrhosis will not be HRS. First, we have to see the volume status of the patient and the precipitating factors, whether the patient is having any nephrotoxic drugs.
The opening statement is absolutely correct. So how will you assess volume status in this patient?
Sir, clinically, I will see, as the patient is already intubated, sir, clinically, in the signs if the patient is dry or not. As
This
a
one
patient,
I'll summarize in the later on. So volume status, this thing needs to be stressed upon. Okay, next, other than volume, so you are basically going to maintain a proper volume, neither hypervolemia, neither hypovolemia. And then other than the maintaining a euvolemic status, what the other therapies you will ensure?
I will ensure, sir, I will exclusion of any nephrotoxic agent to be used, control of the sepsis, and the control of the blood pressures, adequate blood pressures is maintained. And in spite of, after the volume expansion also.
What vasopressor would you choose here, in general and in this patient?
In general, I will choose a norepinephrine for this for the patient, and as the patient presented with a septic shock, and as with the if we are using norepinephrine in case of even if the patient is HRS, I will continue with norepinephrine only instead of terlipressin if the patient, because if the increase there is an increase of MAP, then norepi can also do the work of terlipressin. And if the norepi is not required per se, then I will add to the
Any role of
terlipressin.
albumin?
Yes, sir. Along with the terlipressin or norepinephrine, which the vasoconstrictor we are using, we can use 20 to 40 gram of albumin, 20% albumin for the volume expansion in these patients.
Okay.
But considering the volume status, if the patient is already volume overloaded, then we have to restrict the use of colloids and crystalloids.
Okay. And if there is a refractory AKI, not amenable to whatever the albumin, volume expansion, or euvolemic status and vasopressor therapy, then what can you do?
Sir, if there is a refractory AKI not responding to terlipressin and vasoconstrictor, then I have to think of liver transplant.
Before that, I mean, you do routinely.
So we have to decrease the intra-abdominal pressure.
Okay, so they already said that probably you will going to drain it. Okay, that's a good option. Even after that,
renal replacement therapy. Yes.
Yes, in exam happens that sometimes the basic things doesn't proper. Okay, so what is hepatopulmonary syndrome?
The hepatopulmonary syndrome is a syndrome within the lung, in the background of cirrhosis due to the dilatation of the vessels within the lung, characterized by an increased PA ratio of greater than 10 to 15, and orthorexia and platypnea.
It is gradient. It is alveolo-arterial gradient, not
gradient. Alveolar arterial gradient, and also due and characterized by presence of chronic liver disease, increased arterial alveolar gradient, and hypoxia.
How will you diagnose an HPS? If you suspect HPS, how will you diagnose?
So I will diagnose with a bubble echo, with bubbling echo. I will see if if it is occurring greater than 3 cardiac cycle, it is coming on the other side of the heart.
If it is occurring less than 3 cardiac cycles?
Then it is due to the intracardiac shunt, anything which is within
not
the
an intrapulmonary shunt, it's an
intracardiac shunt.
So albumin has already been described. I would not ask much of it. Now define ACLF.
Yes, sir. ACLF is defined as a systemic inflammation on a background of a chronic liver disease due to a recent onset predisposing factor and having more than one organ failure leading to short-term mortality.
Okay, that should do. Any particular scoring system that you know of which is used to?
Yes, sir. What according to the European Society, what we use is the CLIF SOFA or CLIF COF score.
Okay, good. And how will you prognosticate? Any prognostic tool?
Prognostic tool is the CLIF C ACLF1 score is there. If it is high and then we will prognosticate accordingly. And also the ACLF grading, the ACLF 3 has a mortality of around 85 to 95%. And the presence of respiratory distress, ventilator, vasopressor.
Okay, just mention the prognostic tool. That would be enough. Any other tool? Before ACLF, what previously used to be used most frequently?
Check child pug male scoring and child
Male score.
male
Obviously, male score. Achha. Any other rescue therapies that you know of in ACLF? Just mention them. You don't need to discuss.
Sir, rescue therapy before transplant, we can use CRRT special and the plasma exchange therapy, especially in the alcohol-induced ACLF. And also albumin bypass therapy is controversial. Till now, it has not been accepted, but CRRT and plasma exchange, what I have used, sir, in ACLF, mainly in the alcohol-induced ACLF.
Okay, good. And, you should add focus to your findings. You should add to by yourself only that you have done a focus. It is expected of you that during the examination, you do a focus of yours by yourself. You have an ultrasound, you examine the patient, do a quick 2 minutes focus. So I'm not asking you this question. I would expect, this is a general answer. What is the role of focus in this patient? And how will you assert, the last question for this one is, what antibiotics will you give? So this is a septic shock precipitated by a severe community acquired pneumonia, and that has led to an ACLF. Probably some SBP is also there as per the lab findings. What antibiotics?
Sir, I will start with an BL-BLI combination, and the beta-lactam will be for third or fourth generation cephalosporin. I will start with, and according to the culture, I will modify, and I will also look for in the history if there is any colonization of any MDR or gram-positive bacteria is there in the previous documentation.
For the history, do you have anything in the patient's examination findings on the course that would suggest that you need an MDR cover? Supposedly, you have started the patient with a piperacillin tazobactam and you don't know about it, so probably you started a gram-positive cover with, vancomycin or a teicoplanin. Now the patient is not responding. So without cultures or without background, how will you know that it probably an MDR organism is there?
So one is that the patient is having repeated admission and
currently patient is admitted to ICU. You have started Piptas and Vanco, and then how will you decide on escalation? That's my question.
So as the patient is not responding and the vasopressor is escalating, then
shock. So simple answer is persistent shock despite prescribed antibiotic is an indication of escalation. If you don't have a culture and all those things, that's what you do regularly.
Yes.
Okay, so that concludes the session. I would have very minimal points to add. You have nicely, you have read the this case thoroughly. I don't have anything to add on to the theoretical session. That's lucky for me also. I would add to what particular things you need to focus on. Okay. So first of all, when you are starting, you have to start with a case where you started very nicely till when you said that, okay, this is a 36-year-old gentleman with a history of alcohol abuse disorder and hepatitis B, and he has a history of suggestive of severe community-acquired pneumonia followed by an acute and chronic liver failure. Now the next part is going to be currently being managed in lines of septic shock with multi-organ dysfunction. And ideally, this is what we have been taught in the Vellore campus during that time, is that currently being managed in this, and we expect a bad prognosis. The patient has a guarded prognosis. That's what we are going to tell to the patient's relative. So currently, this is the background. This is the current condition. Now the patient is mostly having a bad prognosis. That is going to be that I'll have to explain to the family. That is the opening statement. This is one point to be noted. Then describe the history. That is you have to basically look at the patient. Remember that you have a time slot that's maximum to 40 minutes, 30 to 40 minutes. Within that time, do not engage much into the details of history. Don't, you are more than welcome to ask the patient relative to give you more history, but you have to justify that. You have a 30 minutes time. Within that, you have to examine the patient. You have to note down the current antibiotics, what is the lab values, and then in between, if you get 5 to 10 minutes, just revise within your mind what you are going to face when you are facing the examiner. how we are going to approach them, or what questions they might ask, how we are going to answer. So if you ask the relatives and all, too much of history, that is not required. So spend 5 minutes in the history, quickly go through the nursing chart, the current fast track bits. Obviously, fast track bits is one thing you have to mention, and then examine the patient nicely. Take 5 to 10 minutes of time. Within that, 2 to 3 minutes, ask for the ultrasound immediately when you are examining the patient. Once the ultrasound comes, examine the patient, take a focus finding, and then at least 1 or 2 lines of recommendation. Like, for example, they might ask what you recommend going on forward. The patient is still on vasopressors, on ventilator. You might suggest, okay, I will escalate the antibiotics. If I will do a nephro referral for call for dialysis requirement. I will counsel the patient's relatives about the bad prognostication and the need for listing for transplant therapy. I will discuss with the ID and my primary team for the liver transplant purpose. And based on the prognosis and everything, I will have to kind of summarize the entire course. So this is what the ultimate recommendation that should come out. So this is the last part of the entire thing. Now coming to the most important part, these are all things which are extremely theoretical. You have already covered. You have to mention SOFA and Apache. Apache, you cannot calculate at the bedside. You need lab values. Do not do that. You at least calculate the SOFA. So SOFA is very easy to calculate. At least calculate and tell that, okay, this is the today's SOFA score. You don't need to tell each and every details of how the patient, what was the initial SOFA and all, but at least mention one SOFA score if you can. And during the examination, be very systemic. The examination of general physical examination is same as that what we used to do in MBBS. So start off with the patients. The patient is propped up. Patient is well built, around 55 kgs. This is the centimeters BMI of this. His propped up position, currently mechanically ventilated, size of 8 tube, and ventilated with an control mechanical ventilation, ACY VC mode. His heart rate is this, his blood pressure is this, he's on dual vasopressors, on NORAD, this one. He has an arterial line on the left radial, he has a right internal jugular central venous catheter, the site of the central venous catheter and the arterial line both seems fine. I have done a first class test and I have checked that the arterial lines are adequately zeroed and level. The patient has an adequate chest rise. The patient has a bloated abdomen, distended abdomen with visible ascites. And then you come to the, he has a pallor. He has, pallor by the nail bits. He has severe icterus. He has got no clubbing. He has edema on the back and mildly on the leg. And he has got, other than the icterus, there is no other significant skin finding. He has got skin thinning of air. Examination of back is also unremarkable. There is no bed sore. Now you come to the last few things that, I've done a POCUS. POCUS shows that this is the echo. Echo looks fine, bilateral basal consolidation, left-sided effusion. So this is the amount. And so this is how you basically complete your physical examination. The general, and you should not, 1 or 2 points, if you're missing, it's okay, but do not miss more than that. You should be systemic in how you approach. And as you said, you mentioned, that's why I didn't mention here, that what is the level of sedation? What is if the patient is having delirium? So patient is adequately sedated, RAS score of this, or if the patient is in hepatic encephalopathy, so obviously the sedation is 3 and in grade 3 and 4. So currently not sedated, hepatic encephalopathy grade 3, 4. We could not assess the patient's delirium status, and patient looks pain-free on the ventilator based on the CPOT scale. So these things has to come in the general physical examination. And the examiner can divert from there. You can check, they can ask you, okay, how will you calculate ventilator compliance and all those things. So do not think that ACLF is only ACLF. They might ask you anything, related to general critical care. Coming to another thing that I must mention here, this thing you have done, okay. Then coming to the other things. So you have examined. After examination, tell about the basic blood work. Then the immediately available test, like an ECG. Then you do the imaging, like an X-ray, and then extra imaging which is required, like a CT scan and all. So most probably CT is not done for the patient. You tell the basic lab findings. The patient has leukocytosis, thrombocytopenia, coagulopathy. Patient has type 1 respiratory failure, lactates of 5. Patient has undergone a X-ray. The baseline X-ray shows this is the. Now they can be asked about. You can be asked about the debriefing the X-ray as well. So this is the X-ray showing a bilateral consolidation or a right upper zone, left lower zone consolidation, so and so. So you brief the X-ray findings, and if there is a CT, you might be asked that as well. After this comes the then you ask, then they go into pure theoretical things. What is ACLF and what is this and that? You have nicely gone in depth about the particular ACLF thing. just these things has to be kept in mind. I'll not discuss about this thing. Alcohol related thing you have missed out. So alcohol related patients will have hollowing of the temporal bone. They will have parotid swelling, and these hyperestrogenic features are more prominent in there. So loosening of hair, testicular atrophy, gynecomastia, these are all much more prominent in these patients. So you can describe on in those lines one or two possible findings about alcohol. I mean, these things comes from the medicine or the MBBS background, but this can be asked. What are the particular findings related to alcohol? And sorry. So next is that you have to next important. Okay, this one you have to mention that whenever an alcohol related question comes, you have to mention about that. Just apologize. Just one question, 1 minute call. Just a quick call. Yeah. Hello. Sorry for the interruption. Okay. So, yeah. So I was saying you have to mention that clinical institute withdrawal assessment scale, CIVA scale for alcohol withdrawal assessment, and MADRS scale. At least mention MADRS score for assessing the severity of alcohol-associated hepatitis or alcohol-induced hepatitis to decide on whether to give steroids and all those. At least two things you have to mention. Okay, portal hypertension, all those things you might be asked. Okay, what extra findings like the tortuous veins and all those things might be asked. Cirrhosis, anything can be asked about cirrhosis, anything can be asked about ascites and the diuretic therapy. So remember that whenever you're telling, first tell that this is a general line of management, then you tell, okay, this patient, because of vasopressinol, you will not give beta blockers and all those things that you have to mention. Management, you have already, this one you have nicely summarized, nothing to add. And HRS, all these things. Okay, assessing volume status. So this you must remember. Whenever an examiner asks, how will you assess volume? You tell that I will look at the clinical findings, the heart rate, the especially important capillary refill time, and the blood pressure, the vasopressor requirement, the urine output. These are the static parameters. CRT is for the microperfusion thing. And then you mention, I would like to look at the heart, the chamber, I mean the pump, the tank pump and the pipes. So this is an opening statement. This takes away a lot of your worries. So they know that what you are telling about. So you will do a quick focus to look at the heart function. You will look at the IVC. Again, in this patient, IVC is not to be looked at. It is in ascites, you cannot look at the IVC. So you will do the dynamic tests. So for fluid responsiveness, then you say because the patient is on ventilator and patient has some severe caps, so probably high tidal volume you cannot give. I would like to proceed with the tidal volume challenge test or an end expiratory occlusion test to do for look at the fluids status, I mean, fluid responsiveness or preload responsiveness. So this completes the statement. You look at that, you tell about the static parameters, you tell the dynamic parameters, and how will you assess fluid responsiveness. Then they can ask about, how will you do PLR and all those things. Again, not important here. This can be asked. And other than that, this thing you have already known. The patient is in shock, multi-organ dysfunction, NORAD to be continued, not in shock, but primarily on HRS, terlipressin. Other than that, OPD patients recovering well, mildly hypotensive, mid-odrin. Either way can be fine. HPS and PPH, purely theoretical questions. I've already mentioned the contrast enhanced echo and all. And again, albumin, big question in any patients with liver disease. Category grade 1 indications you have to know. Then any other areas where it can be asked, what kind of albumin, 5% or 20%, what will you prefer, all those things you have to know. Okay. And so that's it. I mean, other than the definition of APSL, ACLF is not clear cut. It should be an acute decompensation of chronic liver disease, characterized by organ failure and associated with very high short-term mortality. That's a complete definition. There is a variation as to what is exactly the organ failure is. So there are different societies like the APSL, NASCLD, ESL and all. You can simply say that most commonly we use the Cliff SOFA to determine the grading and tailor our therapies. That is okay, especially for SBP. If you want to give antibiotics, whether you give higher antibiotics or not, the Cliff SOFA tells you, gives you a hint. Okay. Regarding the antibiotic thing, that's the last question that today I asked. So whenever an antibiotic policy is asked, you say, okay, you opened up nicely saying that, okay, I start with the beta-beta-lactam combination. You mention something specific. Okay, I'll start with the piperacillin tazobactam based on our hospital policy. And I would like to add a gram-positive cover like a vancomycin. Gram-positive is not a particular term, I mean, not right term, I'm using it loosely. So vancomycin or teicoplanin. Then I will wait for the cultures based on my hospital antibiogram. If the patient continues to be to be septic, shocky, then I would like to escalate to a carbapenem, and I'll continue with the teicoplanin. I'll wait for the cultures, and I'll change it accordingly. In India, I mean, most of the organisms, in this kind of cases are MDR, and most of them are CRE. So probably going ahead with in this cases, going ahead with a ceftazidime, avibactam, or a polymyxin, this is what naturally we do. So that's why, escalation in those terms is very important. So mention about the, how you tackle the ongoing thing, and mention about the risk of fungal organism as well. These patients are very high risk of having almost 20 to 25% having a fungal organism. So mention about the need for a antifungal cover if the patient persists to have organ failure and vasopressor requirement. So that's it. Nicely presented. Just take away point. Just remember, you will do nicely in the exam.
Thank you, sir. Thank you.
Okay. That's it from my side.
Thank you, Dr. Abhishek, and thank you, Dr. Prithviraj, for
Thank you,
volunteering.
ma'am.
I think we can go on to the next session of critical appraisal of research article. And Dr. Paras, are you there? Paras, are you there?
Yes, I am around. Yeah, thank you.
Dr. Abhishek, you can stop your screen presentation. Screen sharing. So you can start the screen sharing right now. So kindly guide us as to we will go to the next page. Next.
Yeah,
next page.
Prithviraj,
So,
you are
so this one will be done by Dr. Gautam.
okay, Gautam. Gautam, have you gone through the BLINK-3 trial, continuous versus intermittent beta-lactam antibody infusion in critically ill patients with the sepsis?
Good evening, sir. Yes, sir. I went through the trial, sir.
Okay, are you ready to proceed?
Yes, yes,
yeah.
sir.
Okay. Can I have next slide, please? Okay. So what was the BLINK-3 trial's primary research question?
Yes, sir. As we know, sepsis is the most common thing, but we are dealing in the ICU. So among this, beta-lactam are the important class of the antibiotics. And as they being a time-dependent antibiotics, they wanted to test the efficacy whether the intermittent infusion was benefit or the continuous infusion was benefit over the intermittent infusion of the beta-lactam antibiotics.
So so they were looking whether the because of the time dependent continuous has associated with a better outcome or not. Yeah, is that right? Yeah.
Yes, sir. Yes, sir.
Yeah. What was the methodology used for BLINK-3 trial?
It is an internationally open label phase 3 randomized control trial, sir. So they have it was done in 104 ICUs across the world. And the participants being adults who were more than 18 years of the age with a documented site of infection, and they should have one or more organ dysfunction criteria to be met, and they should be receiving either meropenem or piperacillin tazobactam within the previous 24 hours, and they should be remaining in the ICU for at least the 24-hour period, the next calendar day, as they quoted. And the exclusion criteria was like those who had received a piperacillin tazobactam for a more than a 24-hour period and age less than 18-year period, sir.
Yeah. So prior to immunization, if they have received more than 24 hours, they were not eligible. Yeah.
And also pregnant or unknown suspected to be pregnant have been excluded from this study, sir.
Or those who are palliative patients or having limits of care. Yeah. No problem. That's good. So it was open label, but it was a randomized controlled trial. Yeah. But investigators, like those who were assessors, were not aware. Yeah.
Yes.
Yeah.
No, sir. It is an open label study, no, sir.
No, the assessors.
Assessors or yes, sir, they were not known.
Yeah, assessors were unaware. Yeah. Participants were aware, but I think assessors were not aware. Okay, that's fine. Good. What were the key findings of BLINK-3 trial, and how do they contribute to existing body of evidence on antibiotic administration in sepsis?
So in this trial, they looked at the primary outcome, that was a mortality at the 90 days, but it did not differ in either of the groups. But coming to the secondary analysis, as they looked at the clinical cure, which was defined by the complete stoppage of the beta-lactam antibiotics by day 14 without need to restart within the 48 hours. Or there was no new acquisition or colonization or infection with a multi-resistant organism. And they also looked at the number of days free of ICU, hospital mechanical ventilation days, and renal replacement therapy up to 90 days. In the they found that there was a clinical cure rate was more towards the continuous infusion group, sir. So it was not statistically significant.
But in secondary outcome, there was one only statistically significant.
I see.
Clinical cure at day 14.
Yes, sir.
Yeah, I was more in continuous infusion as compared, but there was no other statistically significant tertiary outcomes or so. But I think usually the numbers are calculated, the sample size is calculated based on the primary outcome. Yeah. What are the potential clinical implications? How do they contribute to, how this trial contribute to existing body of evidence?
Sir, it has got a good external validity, sir, because it was done across the 104 ICUs. So, but here, as it required a continuous infusion, so in a low economic resource setting, maybe this may not be feasible, sir.
Okay. So, was there any other trials, similar trials done in the past?
Yes, sir. Mercy trial was done, sir. It was with meropenem, continuous and intermittent infusions that they compared. And it also showed benefit with the continuous infusions, sir.
How much was the difference in the outcome in Mercy trial?
There was a difference of 2.5 percentage points in mortality at 28 days, sir.
Yeah. Okay, good. And the BLINK, this was a trial number 3. Was there a previous BLINK trial done, and what was the outcome of that?
Sorry, sir, I did not get this.
You haven't seen that trial. Okay. No. Okay. So this was a BLINK 3. So there was a BLINK 2.
BLINK 2.
Well.
BLINK 2, sorry. I did not get your question, sir. Sorry.
What was the result of the BLINK, that BLINK trial?
No ideas.
Okay, then. No problem. What are the clinical implications of BLINK-3 trial in like antibiotic stewardship and patient management?
So, coming to the ICU antibiotic stewardship program, the continuous infusion favored, it improved the clinical cure rates. So, the duration of antibiotics has been it cut down the duration of the antibiotics as per the BLINK-3 trial. So, it may aid in the good antibiotic stewardship program, sir.
Yeah, and what do you think the limitations of this trial?
First, it was blinding was not done, sir. And although it was a pragmatic trial, and also there was we don't know because they have started on meropenem and piperacillin tazobactam only, and they and generalizedly we cannot comment on to a beta lactam group of antibiotics. And also we don't know about the levels of the antibiotic resistance. So in some center the antibiotic resistant pattern may vary. So that was also the one of the pitfall of this study. And also some participants have randomized according to based on the organ dysfunction. Say suppose if the patient has got an acute pancreatitis, he may be also having organ dysfunction, but he may not be having that to an infectious cause, no sir. So that is also one of the limitations of the BLINK-3 trial, I noticed.
Yeah, good. I think you have answered all the questions well. So I think as you correctly pointed out, the primary research question for this trial was whether continuous is beneficial. They were looking for 3.5% reduction in the mortality and with a 90% power. That is how they calculated 7,000 patients are required to show the benefit. I think, as you correctly said, they pre-specified the subgroup as well, and pre-specified the primary and secondary outcome, which we discussed. Inclusion exclusion criteria are declared. So I think it is a well-conducted trial. Methodology, you correctly said, open label randomized controlled trial. So the clinicians were aware what they are administrating, and continuous and intermittent one. The key findings you clearly mentioned that the primary outcome, which was a 90 days reduction in the mortality, was not statistically significant. It was close to what they used for the power calculation, was 27.5 they were looking for mortality, and they were very close, 25 versus 26.8. So I think the number of patients required to do the study were appropriate. So I think this study they completed. So this was a strength of the trial, that they have got an adequate number. Their calculated sample size was appropriate. That is and findings were there was 1.9% reduction. They were looking for 3.5% reduction. It was not statistically significant. There was a cure rate at 14 days was more in a continuous group. So probably there is a trend towards of benefit. That is how you said antibiotic stewardship point of view. Potentially there is a benefit of a continuous infusion of a beta-lactams, which in principle, based on the time-dependent antibiotic like penicillins, cephalosporins, having a higher time above the MIC level is beneficial for the killing of the bacteria and having a good outcomes. So that is from antibiotic stewardship point of view. From an existing body of evidence, you clearly mentioned Mercy trial and the previous Blink trial results. Limitations, you identified well that this was a study done in a high-income countries as compared to low-income countries. So whether it is a limited resources country, whether it is a possible to use that. So what is the biggest disadvantage of running a continuous infusion? That you will need a dedicated lumen. When patient is very sick on inotrope sedation, medicated and requiring multiple infusions, having an extra cannula, extra dedicated lumen may not be possible. So that is the biggest disadvantages is there of running a continuous infusion. But having extended infusions for meropenem or beta-lactams can be used. So extrapolating results, running a 3 hours, 4-hour infusion is potentially we can use that in the practice, especially in patients where difficult to treat infection like infective endocarditis, recurrent blood cultures positive, or patient with a deep-seated infections. Potentially running a continuous infusion where if you are sure that that bug is been going to killed by mero or piptas or even benpen or benzyl penicillin, or even for an infective endocarditis, or if it is a sensitive bug like sensitive streptococcus. Yeah, definitely, for sure, you can consider in that situation. In principle, yes, it is a beneficial, but whether it changes the patient outcome, that is the biggest question. So it is, again, from a nursing point of view, it is difficult. And the biggest disadvantage of this trial that there was a huge protocol violation, 1/3 in each group, like 34 versus 32 per patient, there was a protocol violation. What was the definition of protocol violation in this trial? Was a delay by 1 hour of administration of antibiotics or stopping the infusion, continuous infusion for 1 hour. So I was a part of a center where Blink trial was was conducted, and patient going for a CT scan, MRI, stopping piptas or meropenem even for more than 1 hour was a protocol violation. So we had to think a lot before doing all these things. So So if you look at that, there was almost 1/3 patient, there was a protocol violation because of stopping infusion for 1 hour or a delay in. And that is a practical reality of intensive care. If patient goes for CT, MRI,
This ends our session of today. We would be doing tomorrow another table vivas. Another set of table viva to be done tomorrow at 6 p.m. tomorrow, same time. And tomorrow we'll declare the class, the special class which Arindam sir was speaking about. We'll declare about the time and date in the tomorrow's class. And I will share the Zoom link and everything in the group. And accordingly, we can all join together. Thank you. Thank you, Paras sir, and thank you everybody for joining.
thank you.